Yes, sir. So
Let me unmute myself. Now I'm audible.
yes, yes, yes. You can start
So
sharing your
yeah, I'll
screen.
be sharing my slides.
Yes, yes, please.
I think it is well visible now. Am I visible now?
No, no, not yet.
Okay.
Your slides are not yet visible.
Yeah, they are visible now.
Yes, yes,
They
yes,
must be visible.
yes, yes. Now you can go
Uh,
ahead.
yeah, good afternoon, friends. At the outset, I will like to thank Chelaram Diabetes Institute for giving me this opportunity in their conference. And thank you, Madam Chairperson and Sir Dr. Umarji for the kind introduction. So today I've been given the task to talk about something which is very common in our clinical practice. And every now and then we come across this kind of challenges in making the diagnosis of diabetes. And there is a one beautiful paper by Dr. Unni Krishnan also on the similar topic. So it was quite helpful for me when I was preparing for the
Sir,
document.
sorry to interrupt you.
Yeah.
Can you put it on a slideshow mode?
It has been already been put on the slide room. Shall I stop to sharing and then again reshare
Yes,
it?
yes. At the time of sharing, you have to choose slideshow mode.
Slideshow mode.
Yes.
So this is again I'm sharing it, and the slideshow mode is downstairs only, no? So
No,
this
no,
is how the now it is. Is it visible now?
no, 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 no. Sir, once stop share your screen, go to your PowerPoint presentation.
Yeah, I'm there.
Then make it on a slideshow mode.
Yeah, the slideshow is that that's so same, na? The last that icon of the small
No, no,
box.
sir. At the time of share screen, you have to select PowerPoint presentation with slideshow mode.
Okay, already I will keep it in slideshow mode first, then I will share it. Is it like that?
Yes, yes, sir. Yes.
Okay, let me do it.
Yes. First, keep it on a slideshow mode. Then after. At the time of share screen, you have to select PowerPoint presentation with slideshow mode.
But somehow it is I've been doing this very frequently, but now it's kind of okay. Let me do it. Is it visible now as a
Yes,
full
sir, right, right.
slideshow? So,
Yes.
difference. So I've come up to this again, but the slides are not moving now. So difference. Sorry for the interruption. There was some technical hitch. So I've been given this task to talk about challenges in type 2 diabetes, especially with respect to diagnosis. Because whenever we diagnose a case, there is always a doubt, and we have a young. Yesterday only, I had a young girl, and the parents were very much reluctant in starting the insulin. So I went for urine ketones. It turned out to be negative, and later on, I just try to have a complete reassurance from them. They will be visiting me within a week or so. Then only I could have gone for oral hypoglycemic agent, because there are similar kind of cases you must have encountered in your clinical practice when they don't turn up early, and they don't turn up late some 2 months down from now and with ketoacidosis. So this is the case one, a girl, now 17 years old, BMI was 20, and had diabetes presenting with moderate hyperglycemia without ketoacidosis at the age of 4 years. And ketones were negative at the time of diagnosis, and C-peptide was 1. The cutoff is around zero point 0.6. And after insulin, the therapy for 1 year followed by 2 years of excellent glycemic control through diet. Only insulin was reintroduced at the age of 7 years. Since then, her metabolic control has been very poor because of non-compliance and skipped insulin injections. HbA1c was 15. This is a routine story which we get in our clinical practice. The evening before admission with DK, she attended a nightclub and consumed alcohol. And this is now getting very common in India. Later that night, she had recurrent vomiting, and at admission was lethargic and signs of severe ketoacidosis and dehydration. Her blood sugar was 1748 and pH was 6.8 and excess space. This is a routine thing. And she was hyperosmotic as expected for a ketoacidosis case. And the C-reactive protein remained low because of the positive family history of diabetes and absence of pancreatic autoantibodies. And genetic testing was performed as previously published, because initially she responded to she was not having ketones. And that turned out to be, dear friends, there is a catch in this case. Initially, you can ask why the patient was not labeled as type 1 diabetes, and later on, she presented with ketoacidosis. This is something rare amongst MODY. But MODY is an entity which is an autosomal dominant type, early age of onset, strong family history of diabetes, 2 or 3 generation history of diabetes in one side of the family, and the onset of symptomatic disease is not certain, can be affected because whenever you come across a younger patient without acanthosis, C peptide around modest C peptide levels, and ketone bodies, ketones are negative. So, dear friends, and if there is a family history, if there is a history of diabetes in the family, you should screen them for MODY because it's not rare, and especially HNF1 alpha and the MODY, the three MODYs are very common in India also. So again, the C-peptide is present at the significant level in body cases, and sometimes there are comorbidities like renal cells. Sometimes there are some other symptoms will give you indirect evidence, and very rarely, since the insulin reserve is low, they can present with ketoacidosis if there is underlying condition which is precipitating it, like type 2 diabetes also can have ketoacidosis. So annihilates and antibodies usually absent. So let's come to case 2. So the first one was a young female which looks like type 1, but she was actually a case of monogenic diabetes. So the second case is a 23-year-old man with a diagnosis of type 2 diabetes since last 6 months and poorly controlled with SU, who initially presented with 2 months ago with polyuria, polydipsia, and asthenia and 6 kg weight loss. This is very common in our clinical practice. And history of past illness was negative. However, his mother relates exclusive breastfeeding during the first 15 years of life, and later he was fed with infant formula. Family history revealed a first degree relative with diabetes mellitus and secondary to steroid administration, and also present second degree family history, uncle and grandfather with type 2 diabetes. There was no pathologic finding at the physical examination. Anthropometry was BMI was 19, fasting was 108, PP was 276, A1C was 8.9. Basal and postprandial C peptide. This is again a very common to assess when we are in a dilemma. 1.9 was the basal value and 3.2 was the stimulated C peptide. Homeostasis, this is again the model. These are research tools, but they tell you regarding the insulin resistance and the insulin reserve capacity. And the presence of autoantibodies, antitrypsin, phosphate, and antibody was there. So antibody was positive, C-peptide levels were modest. He was a young male, lean, thin, looking like as if he was a case of type 1. So this was a case of LADA, which we call 1.5 diabetes. Dear friends, usually initially they respond well to OHA. They have got autoantibodies, and in due course of time, they behave like type 1 diabetes. And they require to be switched to insulin after 6 to 8 months of diagnosis. Let's come to case 3. We have discussed one MODY and then one the LADA case, and this is a 57-year-old previously well female who was referred to a diabetic clinic, had a past history of intermittent epigastric discomfort for the past 9 years, which was initially attributed to and treated for upper GI symptoms. The abdominal pain was intermittent, burning in nature and radiated to the back, associated with steatorrhea and subjective weight loss. No past history of consumption of alcohol or cassava, gallstone disease or hepatitis, and no family history of pancreatic disease or diabetes mellitus. Her initial blood values were in the normal range, but on routine follow-up, she was detected with poor glycemic control with an elevated fasting sugar levels of 128, and A1C was 14.6, phenomenally high. Until now, she was managed for chronic pancreatitis medically by 30,000 international units of pancreatitis. This is what we do when you have cases of pancreatitis. And this ERCP was also done, and stenting was also done. No peripheral stigmata of chronic liver disease, and no features of hemochromatosis. So on X-ray, this is something which is very diagnostic. The pancreas was diffusely calcified. This is X-ray abdomen standing, and involving the head, body, tail, and changes similar to chronic pancreatitis. USG and CT scanning of the abdomen showed pancreatic atrophy and typical bag of stone appearance. Full blood count revealed hypochromic microcytic anemia, and the rest of the things were done as a routine profile. So this was dear friends. Again, we get such kind of patients who have got history of recurrent abdominal pain, diarrhea, and high blood sugars. And when we go for X-ray abdominal stending, we get this typical calcification of pancreas. Dear friends, these are the cases of fibrocalculus pancreatic disease, and it's a unique form of diabetes mellitus, which is secondary to chronic calcification of pancreas in young non-alcoholic individual and exclusively found in tropical countries. The hallmark of the disease are the occurrence of abdominal pain since childhood, pancreatic calculi associated with dilatation of pancreatic duct and fibrosis of the gland in adolescence, also known as pancreatic diabetes, pancreatogenous diabetes, or tropical pancreatic disease. So now we have gone for these three. The classical triad of FCPD is abdominal pain, steatorrhea, the foul smelling stool, and diabetes is associated with overt protein calorie malnutrition. They are very lean and thin because of the protein calorie malnutrition. Absence of other causes of chronic pancreatitis like alcoholism, hepatobiliary disease, or primary hyperparathyroidism. Definitely, we need to exclude these causes. And patients with FCVD usually require insulin, though in small quantities, which is due to the presence of residual beta cell functions. So, dear friends, they have got modest C-peptide levels, but they require insulin in due course of time. Let's come to case number 4. A 49-year-old male was sent to emergency unit because of polyuria, polydipsia, shortness of breath. Also had a rapid body weight loss of 17 kg in last 1 year. He denied any previous illness or contributory family history. And blood glucose was 592, ketones was 4.3, pH was 7.3, bicarbonate 28.5, 14.7, and A1C was 17.8. For the screening for glutamic acid decarbonase autoantibody was negative. Antibodies were negative. An examination was the post facial features, large fleshy nose, frontal pausing, jaw prognathism, acral overgrowth, and thickening skin. Because this case is just pointing out why physical examination and history taking is very important when you are making a diagnosis of diabetes. And the growth hormone they went for was 180 and the normal value was less than 15. IGF-1 was phenomenally high and prolactin level 293.4. And usually they must have gone for the growth hormone suppression test, and that was also positive. The T1 phase with contrast by MRI showed a mass in the pituitary, that is the master gland. And this was the friends, just because of the clinical suspicion, we could make the diagnosis. We went for the investigation and growth hormone suppression test followed by the MRI SELA. It actually proved to be a case of acromegaly, which is around over the 60 to 70% of them have diabetes. And they require treatment, and the insulin resistance and hypersolemia is there, attenuated response to exogenous insulin, defects in both hepatic action and peripheral glucose disposal, and better correlation of disease activity and glucose intolerance is found with serum levels. IGF-1, now we have got normative data. Previously, we did not had normative data amongst the Asian population. So this is the excess growth hormone which led to stimulates increase in gluconeogenesis, lipolysis, hyperglycemia, and elevated fatty acids, and leads to hepatic and peripheral insulin resistance with compensatory hyperinsulinemia. So patients with type 2 diabetes are frequently overweight with excessive visceral fat, which drives insulin resistance. Sometimes, even in case of type A insulin resistance, I don't know, majority of you might not have seen it. They also have features little bit which are coarse. But you need to keep in doubt when you come across that kind of cases for acromegaly. So case number 5 is a 48-year-old man, woman was admitted with fever, cough, left-sided chest pain, shortness of breath, and mouth crisis. Another case, amenorrhea of 1 year duration. This is very important, and the patient was unable to provide a detailed history at the time of admission due to the acuteness of her illness and respiratory distress. So on physical examination, the patient was alert oriented and in moderate respiratory distress with small breathing. And temperature was high, respiratory rate was 20, pulse was 110 per minute, PP was little bit high. Round, flush face with acne, hirsutism, dark purple stripe of the abdominal wall. This is very common in our clinical practice. And I've seen so many patients who are being treated as resistant or brittle diabetes, and they turned out to be something else. Lung examination revealed bronchial breath sounds with crackles in the lower field, and heart evaluation showed normal heart sounds. So, dear friends, So the laboratory features, I will not go in detail with all, but definitely these are the cases on electors. So ONDST was overnight dexamethasone suppression test was performed because on clinical examination there was a doubt that this is a case of hypercortisolemia, and ONDST was not suppressed and the cortisol levels were more than 1.8 microgram per deciliter. Then low dose dexamethasone suppression was also performed. Again, it came with more than 1.8 microgram per deciliter. Then high dose dexamethasone suppression test showed there might be a doubt for some pituitary lesion and ACTH levels were high. So MRI SELA was done and that revealed the presence of tumor. So the prevalence of diabetes mellitus in patients with Cushing syndrome ranges to 20 to 50%. So dear friends, you might be encountering a case of Cushing syndrome, and I was lucky to be part of Professor Amini, and we had a compilation of 440 of Cushing cases. So I've seen myriads of presentation in Cushing syndrome. Definitely, this is very important. And whenever you come across such kind of cases, always look for glucocorticoid excess, and that can be ruled out by overnight dexamethasone suppression test. You need to give just 1 milligram of dexamethasone around 11 p.m. in the night. In the morning, breakfast sample of cortisol. If it is less than 1.8, the chances of hypercortisolemia is less. So let's come to case number 6. 55-year-old man was referred with a persistent cutaneous eruption. This is again a very interesting case. So he was diagnosed with eczema. Patient was asked for his medication history, which revealed that he had been prescribed systemic treatment of oral prednisolone. So although the patient adherence was good, there had been no obvious improvement of the skin disorder, the skin eruption. The skin eruption had started at the lower extremity but had rapidly involved the upper extremities, face, perianal region. It was a migratory skin lesion, and the lesions had presented with advancing borders erosion and crusting, resulting in a scalded appearance. This was a typical necrolytic migratory erythema, as the diagnosis was made by the dermatologist, with erosion and crust formation, and over the top of it had diabetes. So the patient also complained of weight loss. His long-standing diabetes had worsened, and he started insulin therapy. The family history was negative for multiple endocrine neoplasia or diabetes mellitus. Routine and immunological laboratory findings were unremarkable, and serum zinc level was normal. His level of serum iron, and these were done, and skin biopsy revealed soriform acanthosis, parakeratosis, and spongiotic epidermolysis, showing a large zone of necrolysis in the upper epidermis. This was again an abnormal CT revealed a hypervascular tumor measuring 5 to 7 centimeters in the tail of his pancreas, an absence of liver metastasis. So serum glucagon, we had a great difficulty in sending sample for glucagon. This was when I was studying, I was doing my DN course at All India Institute. So serum glucagon was allocated around 1625, and the CT scan, see this is just showing at the tail of the pancreas there is a tumor, and this is something, and see the arrow is very clearly showing it. So dear friends, this was a rare case of glucagonoma. The 4D syndrome consists of diabetes, dermatitis, deep vein thrombosis, and depression. The most frequent clinical signs observed in patients with glaucoma is necrolytic migratory erythema, the typical skin lesion, which was very characteristic in this case. And the symptoms that appear on the skin include maculopapular ring lesions. This is again the theoretical aspect of it. And dear friends, so whenever you are seeing the case of diabetes, it is not just diabetes. There can be so many other permutations and combinations, and that is expected from a clinician of our mind to make the diagnosis. So aside from NME, symptoms often observed in glaucoma are diabetes or glucose intolerance in 80 to 90% of the cases, weight loss. Symptoms that occur less frequently are venous thrombosis, in particular DVT, intestinal motility or alteration with diarrhea and abdominal pains, cachexia, anemia, scotoma, and other optical disturbances. All mucous membranes may be affected by the rash, leading to angulophilitis, glossitis, and stomatitis. Around 33% of them can have it. So 45-year-old women with loss of weight, diabetes, mellitus, anemia, stomatitis, and two vesiculopapular rash. Surgery is currently the only method of curing glaucoma. So surgical resection with curative intent or debulking procedure may lead to long-term palliation. So this is after this, the rash disappears usually after 1 week of the surgery. So, dear friends, today I've been given the task to talk about the diagnostic challenges in diabetes. So, apart from that, the major diabetes the diagnostic challenge is to differentiate between type 1 and type 2. So, usually, when you have got the traditional knowledge of young individual less than 30, lean body weight with ketones positive, definitely that stands today also, but now there are some inclusions in it, like monogenic diabetes. MODY has to be kept into account when you don't have where you don't have a process, and the patient is lean, but the antibodies are negative, ketone is also negative, and the C peptide reserve is there. So, dear friends, the rational use of the diagnostic tools like urine ketones, C peptide levels, the stimulated C peptide levels will definitely help us, and try to look for the history, try to look for, again, be very keen in clinical examination, because you may come across a case like FCPD, you may come across a case which are again maybe hyperpersolemia or growth hormone excess. Rarely you can have a case of glucagonoma. And a week back, I had a case of basically it was again a very rare case where there was an immune disorder which led to the multiple IG4 related diabetes, and that responded to steroid. So that you might say the steroids are bound to increase the blood sugars, but this case was a rare one, the IgG4 related diabetes, which is also a rare entity. So the dilemmas are barriers to clinical judgment, detailed history, the meticulous examinations, the crux of treatment. All permutations and combinations are to be analyzed in a case of interest. Passion, dedication, devotion, and continuous learning is the key to success. Thank you. Thanks a lot for giving me this opportunity in this your wonderful conference. Thank you, Dr. Unikrishan. Thanks a lot.
Thank you, Dr. Chittawar.
For very lucid lecture with very interesting cases. We will discuss at the end. Now, over to the second speaker. First, I will introduce his CV. CV slide, please. Hello. Now, here we have Dr. Ranjit Unnikrishnan, who is Vice Chairman and Diabetologist at Dr. Mohan's Diabetes Specialties, Madras Diabetes Research Foundation, Chennai, which is a fountain of sort of diabetes knowledge in the country. Dr. Ranjit has several publications in the leading international journal and is one of the most renowned diabetologists of India. Now he will be talking about HbA1c, about which so many of us have so many queries and practical difficulties. Over to Dr. Ranjit Unnikrishnan, please.
For the kind words of introduction. I'm very happy that I've been given this opportunity to talk to you about this very important topic, and I would like to thank the organizers of CDI Ideas, particularly Professor A.G. Unnikrishnan, for giving me this opportunity. I've been asked to talk about HbA1c testing, which is a very important component of diabetes monitoring, and I've been asked to talk about some of the basic concepts of this test. So once I got the conflicts of interest out of the way, let's go straight to the topic. So we all know that tight control of sugar is the key to preventing diabetes complications. And when you say tight control, how do we assess tight control? Of course, we can assess control by means of regular monitoring of blood sugars. But we know that even with the repeated use of SMBG, self-monitoring of glucose, and continuous glucose monitoring systems, we do need a long-term index of glycemic control to see what the patient's risk of developing complications is. So now HbA1c, or glycated hemoglobin, is recognized as a gold standard for assessing long-term diabetes control. And over the past decade, it has also emerged as one of the tools for diagnosing diabetes. So what's HbA1c? The term HbA1c refers to hemoglobin molecule. Hemoglobin A is the most common form of hemoglobin in adults. HbA1c refers to hemoglobin A in which the valine residue at the N terminal or the amino terminal has been non-enzymatically bound to glucose or glycated. And the importance of HbA1c as far as diabetes is concerned rests in the fact that it is an index of the mean glycemia, the mean or average glycemia to which the RBC or the red blood cell has been exposed to during its lifetime. And we all know the lifespan of RBC is around 90 to 120 days. So it is around a 2 to 3 months index of glycemic control. But there are certain situations which you should be aware of where the HbA1c may not be a faithful indicator of mean glycemia. So these are some of the pitfalls of using HbA1c. So if you look at the historical aspects, we have known about HbA1c for a long time. In fact, it was in the 1960s that it was first identified. And it was in 1968 that Samuel Rabar, an Iranian physician who later moved on to the US, he was the first to recognize that HbA1c is elevated in people with diabetes. But he did not give any further explanation as to whether it be used as an index of glycemic control. In 1970s, it was recognized that HbA1c is related to metabolic control, but it was not until the 1990s when we had the results of the famous DCCT and UKPDS that HbA1c was established as a clinical marker in both type 1 as well as type 2 diabetes. And in 2010, the ADA, along with EASD and WHO, recommended using HbA1c to diagnose both diabetes and pre-diabetes. Already it had been used for monitoring glycemic control. So something about the terminology, as I said, HbA is the most frequently encountered form of hemoglobin in adults. It constitutes 97% of all the hemoglobin in the adult. It contains 2 alpha and 2 beta chains. There are 4 polypeptide chains. And HbA0 is the native form of HbA, which has not been glycated. HbA1 is a glycated hemoglobin, and the terminology is A1A, A1A2, A1B, A1C tell you what is the carbohydrate that has been attached to the N terminal of the beta chain. For example, HbA1A1, it is fructose 1,6-diphosphate which has been bound to the N terminal. HbA1b, it is pyruvic acid which has been bound to the N terminal. HbA1c is a hemoglobin species in which glucose is a carbohydrate that is bound to the N terminal of the beta chain of hemoglobin A. And the term total glycated hemoglobin constitutes all the hemoglobin molecules to which carbohydrate has been non-enzymatically bound. It includes A1, A1, A1A2, A1B, A1C, etc., etc. The formation of HbA1c is a stepwise process. The first step, the condensation of glucose with hemoglobin to form a Schiff base, is a reversible process. The subsequent steps are irreversible, or at least that's what we thought until recently. We thought that once HbA1c is formed, it does not degenerate and it remains as such for the lifespan of the RBC. Therefore, it is an indicator of the mean glycemia to which the RBC has been exposed over its lifetime. There are different methods for measuring HbA1c. There are innumerable methods. These are only a few. But basically, you can divide them into methods which utilize actual physical separation of various hemoglobin species or chemical separation. The physical separation can be based on either the differences in the charge, electrical charge between the various hemoglobin species, or based on structural differences. And the charge methods utilizing charge difference include the HPLC, which is very commonly used, high performance or high pressure liquid chromatography, and capillary electrophoresis. The methods which utilize structural differences include the affinity chromatography, and the chemical methods, all of them utilize the structural differences, and these include immunoassays as well as enzymatic assays. Now, at least in the United States, all of these have been standardized. 93% of all hemoglobin tests, HbA1c tests in the United States have been standardized by what is known as the National Glycohemoglobin Standardization Program, which has actually standardized it to the assay which was used originally in the DCCT. Unfortunately, in India, the standardization is still not great. So from many labs, we cannot rely on the HbA1c which is coming out. Now, point of care assays are also available. Standardization situation is even worse for those still available in India. The equipment is rather expensive, but it's very convenient to the patient. The latest ADA guidelines tell you that you can use the point of care assays for monitoring glycemic control, but they probably should not be used for diagnosis of diabetes. So we know HbA1c is an index of long-term glycemic control. It's not affected by what time of the day you take the blood, when you had your meal, whether you had exercise, you just taken your drug or not taken the drug, whether you are under any stress, physical or emotional, or whether you are cooperating or not. So it will help you to clarify the discrepancy between the blood glucose values and the degree of overall glycemic control. Now, blood glucose value just tells you the glucose control at a given point in time. HbA1c tells you the overall control over the preceding 3 months. So they're complementary. I would not say they're competing tests, they're complementary tests. Second point is very important, especially in the COVID scenario when you have a lot of people coming in with stress hyperglycemia. Another situation is in the CCU, where you have lots of people coming with acute coronary syndromes, where they are hyperglycemia and you don't know whether they have diabetes or they're suffering from stress hyperglycemia. HbA1c can help to differentiate the two conditions. It's very useful in obstetric practice, especially when deciding when a patient with diabetes can conceive or not. And the second point is that if a person with diabetes conceives, using the HbA1c, you can actually predict what is the risk of congenital anomalies in the baby that woman is going to have. So the recommendations for HbA1c testing are: do the HbA1c test at least twice yearly in patients whose glycemic control is stable and who are meeting treatment goals. If you don't meet treatment goals, your control is brittle, or your medication or treatment has been changed recently, test it at least quarterly once. So what are the recommendations for reporting the HbA1c? The HbA1c report to be complete should include the HbA1c percentage, again, which has been standardized by the NGSP, the actual concentration of HbA1c in IFCC units, millimoles of A1c per mole of hemoglobin, 20, 30, 40, like that. Should also give you the estimated average glucose, or EAG, which has been derived from the ADEX study. And you will see that for every level of HbA1c, there is one value of estimated average glucose. Now, we will see later that it's an oversimplification. There's actually a range of values. But these 3 or 4 things have to be reported in the HbA1c report for it to be considered complete. And these are the targets for HbA1c. You know that different organizations are given different targets. But as a rule of thumb, for your normal person with type 2 diabetes, the target for HbA1c is below 7%. It has to be individualized. In elderly people, very young children, people with comorbidities, you can probably accept a slightly higher level of HbA1c. Whereas in youngsters, or newly diagnosed, pregnant women, in all these situations, you may expect to get a lower HbA1c target. Now, HbA1c can also be used to diagnose diabetes. A value of 6.5 and above has been considered as diagnostic. 5.7 to 6.4 corresponds to the pre-diabetes. You don't call it pre-diabetes, you call it increased risk of diabetes. And below 5.7 is considered normal, but there is a caveat. You can only use this for diagnosis in non-pregnant adults. You can't use it in children, you cannot use it in pregnant women. Assay should be standardized, and the patient should not have any condition that precludes the accurate measurement of HbA1c. So if all these are satisfied, you can use the A1c for diagnosing diabetes. But there are situations where there is a mismatch between HbA1c and blood glucose. All of us are familiar with some of these situations. The commonest situation is when somebody has recently initiated treatment. You know that if you start treatment today, it will take at least a few weeks, if not months, for the effect of that treatment to be visible in HbA1c levels. So recent initiation of treatment can lead to a mismatch. Patient is not complying with treatment. When they come to the doctor only, they take the medications. So naturally, the fasting, postprandial, random, everything will be normal on that day. But the HbA1c will tell you the truth. Recent increase or decrease in glycemia. Suppose somebody gets pregnant, the sugars will go up. HbA1c will take time to increase. Similarly, somebody has just been given steroid. The HbA1c will take some time to go up. And also, you should remember that HbA1c is a weighted average. So events which have happened more recently in the last 3 months will have greater influence than events which have happened remotely. In fact, the preceding 1 month has 70% influence on the HbA1c, while the 2 months prior to that has only 30% influence. Conditions which can be associated with inappropriately low HbA1c. Somebody has lost blood, especially somebody has been transfused with blood from non-diabetic donor. Hemolysis, because young cells come in which are not glycated. Treatment of iron deficiency and folate deficiency anemia. Hypersplenism, consumption of red blood cells. patients who are on hemodialysis, end-stage renal disease, third trimester of pregnancy, and we will talk about some of the drugs. Opposite situation in uremia, especially when you are using some of the older methods, there is increase in carbamylated hemoglobin, which can actually show inappropriately high HbA1c. Similarly, hyperbilirubinemia, alcoholism, following splenectomy, vitamin D deficiency, certain drugs again we'll talk about, and iron deficiency or folate deficiency anemia. So these are some of the clinical situations you need to keep in mind. And these are some of the drugs which can affect the HbA1c. Most of them actually reduce the HbA1c, cause falsely low HbA1c by reducing erythrocyte lifespan. Examples include dapsone, ribavirin, antiretrovirals, Bactrim or cotrimoxazole, and so on. Some of them can actually alter the hemoglobin like hydroxyurea. Some others can alter the glycation like high doses of vitamin C and vitamin E. The drugs which cause falsely high HbA1c are very rare. Very high dose of aspirin probably, and chronic opiate use. Hemoglobin variants, again, in the part of the country where I practice, these are not very common. I'm sure in many other parts of India, they are more common. The commonest variants are HbS, C, B, and D. These are actually point mutations. They are characterized by amino acid substitutions in one point or one spot, especially in the beta chain. And you can have a disease trait as well as you can have actual disease, because beta globin actually has two genes, one from each parent. If you inherit two abnormal genes, you are a homozygote. When you are a homozygote, you are hemolytic anemia. So definitely you cannot use the HbA1c because it will be falsely low. So if you are a heterozygote, homozygote, the question of using HbA1c does not arise. A homozygote, that means you get one abnormal gene from one parent and one normal gene from the other parent. You can still use the A1c depending on the actual variant you have and the test you are using. As amino acid substitution, which is close to the N-terminal, like HbS and HbC, may interfere with the glycation. It may also interfere with the assay, but not with the modern methods. So in such situation, the methods which use total glycated hemoglobin, like immunoassays and boronite affinity chromatography, are considered to be more reliable. The problem is that many of them have not been standardized. So this is not an exhaustive list. If you want more information, you can always go to the NGSP website. This tells you what are all the methods which are affected by each of these variants. And the good thing about using HPLC is that you can actually see the chromatogram and you can detect the presence of hemoglobin variant. In fact, the HPLC has now been used as a screening test for hemoglobinopathies because many of these can actually be picked up. So from one glance at the chromatogram, I can say whether in this particular patient you can utilize HbA1c or not. And that's what generally this flowchart tells us. If you have a variant, see what is the level of the variant. If the variant constitutes more than 40% of hemoglobin, you cannot utilize HbA1c for assessing glycemic control. You have to do some other test, like fructosamine. If it is less than 40%, then we can report the value and say it has hemoglobin S or C. You can report the variant and say it does not affect the result because see, we are using HPLC, which is not affected by any of these. But there are some variants which are unknown. We don't know what the variant is. Then you may have to go for the confirmatory test, that is electrophoresis of hemoglobin. And then you can characterize the variant and decide whether it is affecting your HbA1c result or not. But even in the absence of all of these, there may be some discrepancies in some individuals. And that is because glycation does not take place uniformly in everybody. The same A1C value may be associated with different average glucose levels in different individuals. And this is data from the ADEX study. I showed you this graph earlier. But what you see is that what I mentioned here is only the mean glucose. But look at the confidence intervals, very wide confidence intervals. So that means if somebody's hemoglobin mean glucose is 180, the hemoglobin A1C may be 7, 180 comes here, isn't it? It may be 8 or it may even be 9. So there is a lot of inter-individual variability. And why is that so? That this takes us to the concept of glycation index and glycation gap. What is glycation index? What is glycation gap? The hemoglobin glycation index is the difference between the average glucose obtained from SMBG or from CGM. Nowadays, people are using CGM and the EAG, which is obtained from hemoglobin A1C. So difference between CGM and HbA1c. The glycation cap is the difference between average glucose obtained from fructosamine and the average glucose obtained from HbA1c. Based on that, you can have high glycators, low glycators. High glycators are individuals who have disproportionately high HbA1c for the degree of glycemia. They are high glycators or have a positive glycation gap. Those whose HbA1c is inappropriately low for the degree of glycemia, they have negative glycation gap or a low hemoglobin glycation index. And these tend to remain constant in an individual over their lifetime. Why is that so? There may be some genetic reasons. Ethnicity. For example, blacks in the US are considered to have higher HbA1c for any given level of mean blood glucose. RBC lifespan may vary from individual to individual. For the glucose to get into the cell, you need GLUT1, glucose transporter. There may be some polymorphisms which do not allow the glucose to avidly enter into the RBC. The last point is most interesting. I told you that once HbA1c is formed, it is stable. It doesn't degenerate or doesn't get deglycated. But in some people, it is now shown that there is this enzyme known as fructosamine kinase, which can actually deglycate the HbA1c that is formed. So in such people, the HbA1c level will underestimate the mean glucose. So all this information is coming more and more now that we have more access to the CGM technologies. So what are the implications? People with high glycators have been shown to be at risk of incident cardiovascular disease in East Asian population, probably because they also glycate other molecules, leading to formation of advanced glycation end products. But this link has not been shown in many of the other studies like ACCORD, Advanced, or DCCT. The ACCORD study, what they found was that, you know what happened in ACCORD is a bit. They tried tighter than tight glycemic control, tried to get people to HbA1c below 6.5, and then ended up increasing mortality. The people who died in ACCORD, who had adverse outcomes in ACCORD, were the people who had high glycation. So these were people whose HbA1c was inappropriately high, and they were being treated inappropriately aggressively in an attempt to bring down the inappropriately high HbA1c. Probably that led to recognized or unrecognized hypoglycemia and adverse outcomes in those patients. So I would like to finish by saying that discrepancies, HbA1c is a very useful test. All of us use it, but you should be aware of the discrepancies. They are infrequent. Majority of people, whatever average glucose is mentioned in the ADEX study, holds good for them. But most of the clinical situations which are associated with artificially low or high HbA1c are easy to recognize. Mostly you can get it from a good history, good drug history and good treatment history. But inter-individual variability, and how this has come out is because people have started using continuous glucose monitoring more. And we find that you monitor the glucose levels and actually we find an estimated average glucose from that and back calculate the HbA1c. There is a definite difference between that HbA1c and what you get by actually measuring the hemoglobin A1c by HbA1c or any other method. Now, if you have that sort of discrepancy, which value you should look at? See, the thing to remember is that diabetes complications are not caused by HbA1c. Diabetes complications are caused by high blood glucose. The only reason we are forced to use surrogate markers such as HbA1c is that until now, we had no way of continuously monitoring the glucose levels in any given patient for any considerable amounts of time. And that has now been obviated by the advent of CGM technologies like the flash glucose monitoring and all that. And I'm sure, I think the future tendency or the future trend would be to rely less on the A1C and more on the continuous glucose monitoring. So as continuous glucose monitoring technologies develop, they may ultimately obviate the need for these surrogate markers. But till such time, HbA1c remains the gold standard. I thank you for your attention, and I will be happy to take questions whenever the time for discussion arises. Thank you.
Thank you, Dr. Unnikrishnan, for a very lucid presentation of a very difficult topic. We'll have discussion at the end. Now, we'll move to the next speaker, Dr. Vedavati Purandare. Her CV, please. She is a product of BJ Medical College, very meritorious student, and she has been consultant physician and diabetologist at Chellaram Diabetes Institute. We can call her backbone of Chellaram. She has received Dhirubhai Ambani Scholarship and was awarded Vasant Baum Prize for her academic performance. She has a number of scientific publications in national as well as international journals. Her work on renal disorders in diabetes, a very important topic, was presented in a conference. She was regional faculty for advanced certificate course in prevention and management of diabetes and CVD. Very glad to present Dr. Vedavati Purandare, very enthusiastic researcher.
And friends. After the excellent sessions by the previous speakers, now I will be discussing on designing a complication screening protocol in diabetes. This session would be more of practical aspect or will be having more of clinical background and less of the theory part. In this session, we will be seeing how to increase the compliance of patients regarding screening of diabetes complications. So what are the goals of diabetes treatment? The two major goals are, one is to prevent complications of diabetes and second is to optimize quality of life. We treat hyperglycemia in diabetes because the research shows that if this hyperglycemia is not treated, the chances of complications are high, mainly the microvascular complications. So, while we manage hyperglycemia, it is very important to screen for the complications. The medical staff, we all know that screening of complications is important, but it is very important for patients and the relatives to understand the importance of complication screening. The second goal is optimize quality of life. Quality of life is very important for all, mainly the diabetes patients. If they don't have symptoms earlier in the complication phase, and if we treat and diagnose the early complications and prevent the progression of complication, the quality of life is preserved. But if patients procrastinate, they don't screen for complications and patients are diagnosed with end-stage kidney disease, then we all know that renal replacement therapy, the quality of life is not that great. Even in retinopathy, if it is diagnosed very late in proliferative stage leading to blindness or vision disturbances, the quality of life is hampered. So the main goals of diabetes care, prevention of complications and optimize quality of life, screening of complications is very important. When we treat a person with diabetes, we are thinking about that patient for long term. So for that, we have to develop a plan for continuing care. It is not only a single visit, but it will be multiple follow-up visits with the doctor and the patient. And the approach towards diabetes treatment should be with this chronic care model. The chronic care model in which the patient or the person with diabetes is at the center and the patient is taken care by a multidisciplinary team with members like a physician or diabetologist, endocrinologist, podiatrist, dietitians, ophthalmologist, nephrologist, diabetes educators, etc. And the team members manage person with diabetes in a holistic way. If the communication between the team members is good, it will have a beneficial impact on the diabetes care of the patient. Like if a foot surgeon and a diabetologist have good communication while they are managing a patient with diabetic foot and hyperglycemia, that will improve patient care. Similarly, if a patient with diabetic kidney disease and heart failure, if the cardiologist and nephrologist, they communicate with each other regarding potassium, regarding the blood pressure, then it always will have good impact on the patient's well-being. It is not important to screen only when patients are in diabetes phase, but also in pre-diabetes phase where we are screening patients for diabetes. We have to screen them for increased risk of cardiovascular disease and the risk factors related to cardiovascular disease like hypertension, dyslipidemia. So it is important to screen pre-diabetes subjects also. While we see the goals of diabetes management, in addition to glucose control, blood pressure control, lipid control, prevention of complication is one of the important goals. And in addition to lifestyle modification and pharmacotherapy, regular monitoring is very important. In regular monitoring, glycemic monitoring, the individualization of frequency of glucose monitoring is there. And apart from glycemic monitoring, the complication screening of diabetic retinopathy, screening for diabetic kidney disease is very important, which we will discuss further. These are the chronic vascular complications of diabetes, and mainly there are guidelines to screen how diabetic kidney disease or diabetic retinopathy, how diabetic neuropathy should be screened, and there are also guidelines to screen the macrovascular complications of diabetes, mainly the coronary artery disease, cerebrovascular disease and peripheral arterial disease. These macrovascular complication screening mainly depends upon the signs and symptoms. So there may not be a fixed frequency to screen them, but if patients develop feeble peripheral pulses, we may screen patients for peripheral arterial disease. If patient complains of angina, we may screen patients for coronary artery disease. In addition to vascular complications or other complications also, we need to screen patients for associated comorbidities also. Like patients with diabetes have increased chances of hypertension. So every clinic visit, we have to check blood pressure of the patient. Lipid monitoring depends upon individual to individual. The frequency varies and we will see in further slides. We need to screen patients for NAFLD. So monitoring of liver function test, liver enzymes, transaminases is important. Then cancer, we all know that the risk of cancer in diabetes is high. So age and gender appropriate cancer screening recommendations should be there, and reduction of reduction of risk factors which increase the risk of cancer, like smoking, obesity, physical inactivity, patients have to work on this. Very importantly, we need to screen our patients with diabetes for psychosocial issues. We are getting many patients with diabetes distress, and we are getting patients with anxiety, depression, emotional eating. So such things also need to be screened and need to be evaluated. So we have guidelines which tell us how to screen patients of diabetes for complications, but it is not that easy because there are some practical difficulties, mainly in our country like India, because not all patients are happily or willingly want to screen for complications. So we will discuss first the practical difficulties while implementing these guidelines in clinical practice and what are the possible solutions. And second, we will discuss the recent guidelines to screen these complications. So first, very important practical difficulty is to convince the patient for checkup. We know while we practice in our day-to-day clinics, the symptoms, they drive the investigations. So if a patient with pyrexia of unknown origin is having fever last 1-2 months, will be willing to do n number of investigations, including CT scans, PET scans, to get the diagnosis. But patients with diabetes, those who can read normally, those who can see their televisions, their computer screens, may not go for eye checkup because they feel that if I don't have symptoms, I may not have any complication. One of our patients told us that he went to his diabetes doctor and diabetes doctor asked him to do retina checkup, and patient told the doctor that I don't have any problem, and still because of the doctor's advice he went to eye checkup and the eye checkup was normal. So he went to another doctor and told that because I was telling the patient that my eyes would be normal and this doctor is unnecessarily telling me to investigate, I have changed the doctor. So such remarks of uneducated patients are coming to us. So to improve the awareness of patients and to convince the patient for checkup is important. Patients tell us my creatinine is normal, so my kidney function is normal, so why you are advising urinary albumin to creatinine ratio? So such answers we have to give patients in this Google era where patients are coming to us with half knowledge and they are asking questions and they are reluctant to go for the checkups. Second important thing is they feel that screening and investigations is inconvenience and the cost of test is enormous. So patients, they don't want to go for an eye checkup because the pupil dilatation needs time. Then after that dilatation, they are not able to see properly for next 2 hours. So they feel that it is inconvenient to go for eye checkup. And sometimes they feel that the urine ACR test, which is costing around 700-800 rupees, and retina checkup, which is also costing around the same, is costly, and because they don't have symptoms, it is waste of their money. But for these misunderstandings, for these queries, our medical team should be ready to answer. Third difficulty is patients are anxious about a new disease label. Patients, they say that I already have a chronic demanding disease, which is diabetes. I don't want to check my lipids because I don't want to get that label of dyslipidemia. I don't want to do my stress test because if it is positive, I will have to go ahead and do further investigations. So such is very common anxiety of our patients. And importantly is in our country, the consultant to patient ratio is adverse. So I know many of my seniors, my friends, they are seeing around 50 to 100 patients of diabetes in their day-to-day OPD. And it becomes difficult to check each and every patient's file and to see when this patient's eye checkup or retina checkup was done, when this patient's creatinine, urine albumin to creatinine was done. So how to have some practical solutions for these difficulties, we will see. Very importantly, during the first consultation, either the consultant or the diabetes educator need to counsel the patient, and all of us have either desktop or laptop in the clinic in this era, and we can have some photographs which after seeing patients may not feel panicky, but at least patients' education level will increase. We have to show them kidneys, how albuminuria occurs and why to do urine albumin to creatinine ratio. Then we can show them fundus photography. We can tell them that if your retinopathy is not there now, after 1 year, if the mild NPDR status comes, then why the frequent retinopathy testing is to be done. So accordingly, we can counsel that early screening of complication, some of the complications can be reversible. But if we diagnose the complications in advanced stage, the reversibility component becomes very less. So if we counsel in then these days we give consultation notes and the prescription, which is usually from the hospital information system, and we can have draft of the consultation notes, which in addition to emphasizing on lifestyle modification, pharmacotherapy, should mention that how regularly patient has to screen for complications, like how frequently kidney function test or retina test is to be done, so that at least patients, when they go home and read these consultation notes, they have the knowledge why these tests are to be done. Then inconvenience. Patients, they say that doing eye test in 4 hours in one clinic and doing laboratory test in one laboratory for 2 hours and going to cardiologist for 3 hours becomes, they have to go to multiple posts and they have to spend lot of time. So if in a hospital where diabetes patients are coming regularly in good numbers, we can have small list of investigation which can be given as small diabetes checkup or comprehensive diabetes checkup. In the basic diabetes checkup, the glucose levels, A1Cs, lipids, creatinine, fundus photography, ECG, and basic diabetology consultation and diabetes educator consultation regarding diet and exercise can be planned. And in our hospital, we do this in 2 to 3 hours. And if patients, we feel that he needs or she needs a comprehensive evaluation, in such patients, we can have a comprehensive list of investigations which includes 2D echo, treadmill test, neurovascular evaluation of feet, and then detailed consultations of all the specialists. Then very importantly, patients are anxious about a new disease label, but we as a team, medical team members, we all should counsel patients that if the cholesterol level is high, we can control it with statins, and this will directly have a good impact in prevention of cardiovascular disease. Even patients are reluctant to check creatinine because if they think that creatinine is high, then patients have to go directly on dialysis. But educating patients, making them more aware that if your creatinine is mildly elevated, we can see is there any reversibility component in that, and we have to handhold them and educate them that don't worry, do these investigations and we will try to fix if they are abnormal. And we have such magazines which educate the patients related to diabetes, and they alleviate the anxiety in patients. Then consultant to patient ratio, as we discussed, that one consultant is seeing 50 to 100 patients per day of diabetes. So in such scenarios, it is a good idea to have such kinds of tables in the consultation notes where quickly patient is asking the patient, the doctor is asking the patient, when did you do your last checkup, and patient will tell the date or the year, and patients will also know, and the consultant will also be aware that when these investigations were done. If consultants are busy and if they are fortunate to have a diabetes educator or a diabetes nurse, the diabetes educator or nurse, in addition to teaching patients insulin techniques, glucometer techniques, she can also record the months or the year of complication screening, so that this form, when the consultant and the patient sees, they will get an idea when the next complication screening date should be planned. Now, after seeing these practical difficulties and the tentative solution options, we will now discuss the recent guidelines to screen complications. To screen microvascular complications, first is diabetic retinopathy. These are the stages of diabetic retinopathy, from mild non-proliferative diabetic retinopathy to proliferative diabetic retinopathy. And as per the recent ADA guidelines published in January 2022, dilated and comprehensive eye examination by ophthalmologist or optometrist is recommended. Retina photography is not a substitute for a comprehensive eye examination. And when to start screening for retinopathy? In subjects with type 1 diabetes within 5 years after the onset of diabetes, and with subjects with type 2 diabetes at the diagnosis, we start screening for diabetic retinopathy. And how should be the follow-up visits, or how should be the retinopathy checkups planned further? So if no retinopathy for one or more exams, the fundus exam can be done every 2 years. If retinopathy is present, at least annually the fundus examination should be planned. If the retinopathy is progressing, then the retina checkup should be done more frequently. Women planning pregnancy, we know that diabetic retinopathy, if females become pregnant, it can progress. So if females are planning pregnancy, the retina checkup has to be done at preconception or in the first trimester, every trimester, and also 1 year postpartum, as indicated by the degree of retinopathy. Now, after retinopathy screening, we come to the screening for diabetic kidney disease. We know that these microvascular complications can be asymptomatic initially, and even if they don't have symptoms, we need to screen them. So DKD screening should be done at least once a year, and we need to assess two things. One is spot urinary albumin to creatinine ratio, that is UACR, and second is by estimated glomerular filtration rate, EGFR, by seeing the creatinine value. And when to start screening? Same as diabetic retinopathy, in type 1 diabetes, within 5 years of diagnosis, type 2 diabetes at the time of diagnosis, and subjects with diabetes and comorbid hypertension we need to screen. So why UACR if we are interested only in albumin urea, but only measurement of urinary albumin can give us false positive or false negative results. So if a patient is severely dehydrated, the albumin can be falsely high. So to avoid this false results and to get flawless result, we are doing this UACR, which is a constant in which we divide urine albumin in milligram to urinary creatinine in gram, and this is a constant and which does not give us false results. And urine ACR normal is less than 30 milligram per gram and more than 30 milligram per gram is albumin urea. Now, estimation of glomerular filtration rate, many of the laboratories, while we order serum creatinine test, they give eGFR as we see in this report. So if UACR is more than 300 milligram per day and GFR is less than 30 to 60, we need to monitor twice in a year. Usually if the reports are normal, we do once a year, but if the reports show in this range, we do twice in a year. There are various online eGFR calculator apps which are available. So if the lab is not giving us eGFR, these are the eGFR calculators. We can see here that a 68-year-old male patient of India, creatinine 1.62, and results we get here that eGFR is 46. So just by a click we can get eGFR. Then coming to diabetic neuropathy, the screening recommendations. We have to screen for diabetic neuropathy at the time of diagnosis of type 2 diabetes and 5 years with after the diagnosis of type 1 and at least annually thereafter. And how to screen? One is careful history in the form of positive and negative symptoms of neuropathy, then assess temperature and pinprick sensation and vibration sensation by using tuning fork, which will tell us about the large fiber function, and annual 10 gram monofilament test to identify feet at risk for ulceration and amputation. And if we find patients with microvascular complication, it is good idea to screen them for autonomic neuropathy in the form of postural hypotension, in the form of skin changes when we do foot examination. Then to screen macrovascular complication, we will start with coronary artery disease. So in diabetes patients, if they are asymptomatic, routine screening for coronary artery disease is not recommended as it does not improve outcomes as long as risk factors are treated. So if a patient with type 2 diabetes is coming to us, if patient's blood pressure is in the target range, weight is okay, patient is not smoking, LDL cholesterol is below 100, patient is doing regular exercise. So if we are managing all these risk factors, the routine screening of coronary artery disease is not recommended. So when to do the screening, we will discuss further. But the risk calculator by the American College of Cardiology called as ASCVD Risk Estimator Plus is very simple tool to estimate 10-year risk of first ASCVD event, and this can be used for patient at least to improve the lifestyle. If patient is smoking, if patient is not exercising, this calculator can be used because this app will give us a risk score, and if it is moderate risk score, then lifestyle can be intensified. This Risk Estimator Plus app is to be used only for primary prevention. So it has to be used only if patients don't have atherosclerotic cardiovascular disease. And the parameters which we have to fill in the app is one is age, then gender, systolic blood pressure, diastolic blood pressure, total cholesterol, HDL cholesterol, LDL cholesterol, history of diabetes, smoking, on blood pressure treatment, statin and aspirin treatment. So this is the ASCVD Risk Estimator Plus, in which the blood pressure has been entered, the cholesterol values are there,
नाही मॅडम SRD म्हणून काहीतरी आहे, बाकी सगळं बंद होतं. चालू आहे आपलं, चालू आहे. ऐकू घ्यायचं.
Thank you so much, ma'am, for a beautiful presentation. Thank you very much. In short of time, we will end up with this session. Yeah, and again, we will begin at 4:30 p.m. and 3 to 4:30 p.m. we will be having inauguration in Banting Hall.
Any time for questions?
So we can have a couple of questions, sir.
I wanted to ask, what is the difference between West and India as far as the emphasis on complications sort of detection is concerned?
So we are screening, we are following ADA guidelines only for complication screening, but in Indian settings, we do screen patients for coronary artery disease frequently because we know that the risk of CAD is high in India.
And infections like tuberculosis?
Yes, sir. Means infections also we do see they are high in India as compared to Western countries. So definitely as per the symptomatology, we screen patients for it, sir.
For Dr. Ranjit Unnikrishnan, I would like to ask, why not do whole hemoglobin electrophoresis so that we'll come to know hemoglobinopathies also?
We can do that, but the thing is, at least in the place where I practice, hemoglobinopathies are exceedingly rare. So I don't think the yield of doing electrophoresis is going to be that high. You find it, the more practical way would be to look at the chromatogram, and you find an abnormal peak, then do an electrophoresis to pick up what variant we have.
Because in Maharashtra, they are fairly frequent.
I know, yes, Maharashtra, Middle East, Northeast, Punjab, all these parts of India, hemoglobinopathy, different types of hemoglobinopathies are more common.
Yes, yes. And what about the fructosamine test, or now we are not doing in pregnancy?
Fructosamine, again, if you recall in one of my slides, I talked about the glycation index and glycation gap, one of which was utilizing fructosamine. The problem with fructosamine is if it's difficult to measure and standardize A1C, fructosamine is even more difficult. Very little standardization going on. It has not been validated either for complications or for diagnosis of diabetes. So we hardly do it, only in certain cases, for example, pregnant women and those who come back for follow-up after 2 weeks. And even now that has been replaced by the continuous glucose monitoring.
And what is your opinion about HbA1c camps? Many people conduct camps. Many companies are now conducting camps of.
We have these point of care machines. I think that's what they use for the camps. There are a few, around 30 of them have been approved by the US FDA. I do not know if in India any of them have been approved or if anyone even thought of obtaining approval. But one thing they have shown is that you should not be using these point of care devices for diagnosis. You can probably use them to assess the control, of course, with the caveat that they should have been US FDA approved, but you should not be using them for diagnosis.
And for Dr. Chittawar, I would like to ask, he has mentioned all other endocrine disorders, but what is its experience about thyroid disorders and diabetes? I think, is he there? Dr. Chittawar? Sachin is not there. And what was the experience of Veda during these 2 years of Corona? Whether people were coming regularly for follow-up and all?
Yes, sir, definitely the regular follow-ups has affected COVID, but telemedicine and online consultations have helped. So patients who were staying far away from the hospital, they could get their creatinine at least done by home collection of labs, and other investigations, they were not done on time, maybe the fundus checkup or so, but online consultations have helped for at least for glucose control and other advice.
And for GDM, what follow-up would you recommend regarding sugar, how frequently, like that? You have told about retina, eye checkup, etc.
Yes. So for pre-gestational diabetes, it is recommended that retina checkup to be done at preconception and every trimester, and also after the delivery. Post-conception, at least within 3 months.
Yeah, that is for retina, for sugars and other parameters.
Yes, glucose levels, sir, we tell GDM patients to monitor on glucometers. As per the guidelines, the patients those who are taking insulin, they have to check at least 3 to 4 times in a day on glucometer. And there are few studies which have shown that those GDM patients managing their glucose levels on lifestyle modification with diet and exercise plan, they can check alternate days also. So alternate days, 2 to 3 readings, and just to see whether the readings are in the target. If the glucose levels are increasing, then they have to do every day also.
After delivery, I'm asking next 1 or 2 years or 10 years, whether.
Okay, so they have to do their glucose level check after 6 weeks of post delivery, and then accordingly it is recommended after seeing those values either 3 monthly or once a year.
Any questions from the audience? Or Dr. Anuja Mahajan? Is there
No, sir.
time or?
No, sir.
No, sir.
We can end the session now.
Yeah.
Yes, sir. Thank you, sir. Thank you.
Thank you. I am really honored by Chellaram for making me chairman.
Thank you so much. Thank you so much, Dr. Ranjit Unnikrishnan sir, for joining, Umarji sir for joining us, and also Dr. Chittawar sir. Thank you.
त्याला पुढं ऐकायचं थोडं. मॅडमचं ते ऑपरेशन आता खूप वेळ लागेल कदाचित. जाऊन घ्यायचा थोडं मला. आपण हे करून बघू की याच्यावरून लिंक लिंक आहे ना, त्याच्यावरून मला मोबाईलवर ऐकता येईल का? काय झालंय, आमचा घरचा तो जो कॉम्प्युटर आहे तो अजून झालं मला आता
Good afternoon, everyone. Once again, welcome to the conference. After our inauguration session, we will again start with the lectures. And in this session, we will look for diabetes related complications. So in this session, we will be having 3 lectures by Dr. Ravindra Panse, Dr. Savita Bhatt, and Dr. Charan Bale. And the chairperson for this session is Miss Kavita KV. Over to you, ma'am. Sorry, can you display CV? Please display the CV. Next. You can display the CV of speaker, Dr. Ravindra Panse. So Dr. Ravindra Panse has done his orthopedic specialty, and he is a chief for diabetic foot surgeon at Chelaram Diabetes Institute, and he is one of the eminent surgeon in the city of Pune. He has done his postdoctoral certificate course in diabetic foot surgery from Amrita Institute of Medical Science, Kochi, and he is one of the best surgeon who takes care of all diabetic foot related complications. Dr. Panse, over to you. Dr. Panse?
Hello.
Please proceed. Please play Dr. Panse's video, please.
Yeah, ma'am.
Diabetic foot and ankle surgeon working at Chelaram Diabetes Institute, Pune. I will be speaking on foreign bodies in diabetic foot. We'll be discussing 3 interesting cases. People with diabetes have higher risk of developing foot problems in presence of loss of perception, especially who walk bare feet. Foreign body injuries are quite common and are more common in people who walk bare feet. Diabetic foot with a foreign body can cause devastating foot infections, leading to gangrene, foot amputations, and sometimes can be life-threatening. Case 1. This is a 70 years old lady, type 2 diabetic since 18 years. She has both feet severe neuropathy. She has a history of walking bare feet and history of recurrent plantar callus at the level of interphalangeal joint, left great toe. She presented to the OPD for callus scraping. You can see pre and post scraping images. While scraping, a shiny object underneath was found. So a portable X-ray of the foot was done. It showed tiny radio-opaque foreign body. The circled area in the image shows the foreign body. Careful scraping was done and foreign body was retrieved. It was a small piece of aluminum foil. Check X-ray was also done. It confirmed no remnant radio-opaque foreign body. Clinically, it was a non-infected ulcer underneath the callus. After taking detailed history, it was found out that she used to work in the kitchen bare feet, packing the tiffins with a aluminum foil. Case 2. 64 years male, farmer by occupation, type 2 diabetic since 12 years with moderate neuropathy of both the feet. Has history of barefoot walking in farm fields and indoors. Gives history of thorn injury on feet on multiple occasions. Thorns were retrieved by local doctor. This time he presented to the OPD with a wound with a pseudopurulant discharge on dorsal aspect of the right foot at the level of fifth metatarsal head. You can see the image. Surrounding redness and warmth was present. Discharge was sent for culture and sensitivity, and foot X-rays were done, which showed dense soft tissue shadow along the fifth metatarsal. Intravenous antibiotics were started. After 2 days, there was not much of clinical improvement. So local ultrasound of the foot was done. You can see the image. It showed a linear radiolucent foreign body underneath the dorsal skin along the fifth metatarsal. So in the operation theater under spinal anesthesia and tourniquet, foreign body was retrieved and local debridement was done. Post-surgery repeat ultrasound showed no foreign body. Foreign body was a wooden splinter measuring approximately 2.5 centimeter by 0.5 centimeters. He must have got this injury walking bare feet in the fields. Case 3. This is a 66 years male, type 2 diabetic since 12 years, with severe neuropathy of both the feet. Had history of occasional barefoot walking indoors. He presented to the OPD with swelling on the right great toe with surrounding redness and a plantar wound. You can see the image. Labs were done which showed raised WBC count. Foot X-ray showed a radio-opaque foreign body on the plantar aspect great toe. You can see the X-ray image. To assess the depth from the skin surface, local ultrasound of the toe was done which showed echogenic foreign body approximately 6 to 7 millimeters deep from plantar skin surface with surrounding collection. In operation theater under anesthesia with image intensifier guidance, foreign body was identified and retrieved. Collection was also drained. Foreign body was a small piece of glass. Clinical evaluation and imaging modalities are vital for the diagnosis of foreign bodies that may be either radio-opaque or radiolucent. Early identification of foreign body and intervention can help prevent foot problems and foot infection, thus saving the limb. Foreign body penetration is a severe injury that may cause significant problems when ignored. People with diabetic feet neuropathy should daily self-examine the feet and their footwear. They should also wear diabetic sandals or shoes with MCR insoles. Thank you.
Thank you, Dr. Panse, for the wonderful presentation. It's actually a very important topic. Foreign bodies are often missed in our day-to-day practice, which is very important to diagnose to save the limb. Now I call upon Dr. Savita Bhatt. Can you please display the CV, please? Dr. Savita Bhatt needs no introduction as she was already introduced. She is one of the most eminent ophthalmic surgeon at Chelaram Diabetes Institute and in the city of Pune. Over to you, Dr. Savita. She would be speaking on case studies in diabetic retinopathy. Dr. Savita.
And a very warm welcome to the 6th International Diabetes Summit. I'm Dr. Savita Bhatt, consultant ophthalmologist at Chelaram Diabetes Institute, and I'll be speaking to you on case studies in diabetic retinopathy. So diabetic retinopathy is the most frequent cause of preventable blindness. Globally, 1 in every 3 diabetics will have diabetic retinopathy and 1 in 10 of them will have vision-threatening diabetic retinopathy, either proliferative diabetic retinopathy or diabetic macular edema. So before we embark on the case examples, let's look at how a normal fundus appears. On to your left is the picture of a normal right eye fundus. The central dark areas on both the pictures represent the areas of maximum vision. It is the area of fovea surrounded by 6 millimeters of macula, and onto the nasal side is the optic nerve, an oval structure, and emanating from the optic nerve you can see the retinal blood vessels, both the superior and inferior arteries and veins. Now before we go on to our case example, let us just refresh our memories about classification of retinopathy. They are broadly classified into non-proliferative diabetic retinopathy, which can be further subclassified into mild, moderate, severe and very severe, and the proliferative diabetic retinopathy. Any of these stages can have diabetic macular edema or DME. It could either involve the center of the retina, center of the macula, or it could be next to the macula, so center involving or center not involving diabetic macular edema. So coming to the mild non-proliferative diabetic retinopathy, this is represented by few or one or two dot and blot hemorrhages on the background of the retina, which represents the saccular outpouchings of retinal capillaries. This is the beginning of diabetic retinopathy. If these changes further increases and has lipoprotein leakage onto the surface of the retina, looking like the picture in the moderate fundus picture, it will form a round circular structure above the fovea, representing cercinate of leaked lipoproteins. It can also have fluffy areas of cotton wool spots, which represent axoplasmic transformation deficits or which represent abnormalities on retinal nerve fiber layer. Multiple such findings of cotton wool spots represents that the retina is going into ischemia. So once if you show these pictures to the patients, they may still have 6/6 vision. When you show their retinal fundus pictures, they realize that what is the damage being done to their retina, and they are more careful about controlling sugars. So if the changes are more severe and they further progress with uncontrolled sugars, blood pressures and cholesterol, they form darker areas of these yellow circular areas, like seen in the picture of severe fundus picture. We diagnose severe retinopathy by the classic 4-2-1 rule. 4 areas of the fundus having microaneurysms, 2 areas of venous beading, and 1 area at least of IRMA of intraretinal microvascular abnormality. Any of these findings will put the retinopathy classification into severe. If there are more than 2 of 4-2-1 rule, then it is called very severe diabetic retinopathy. These changes further increases and the retina goes into ischemia and ends up forming new blood vessels at the interface of the retina and the vitreous, and you can see that there are localized areas of fine frond-like new blood vessels which can rupture at any time, causing vision threatening blindness. So if these occurs at an area away from the disc, around 2 disc diameters, then it may not affect the vision as much, but if it is sitting on the disc, it is more sinister and represents a very large amount of ischemia to the retina. So it requires immediate therapy, and it is not necessary that the sugar should be absolutely controlled. Very often we can take the help of the physician, treating physician, and tell them to simultaneously control the blood sugars and simultaneously do the treatment for the retina, so that a substantial amount of the vision is salvaged. If the patient does not present to us at the appropriate time, the new blood vessels can often bleed with a very trivial trauma, often lifting some objects or jerk, and it can have such areas of representing bleeding into the retina. The first one, as you can see, it is a tabletop sort of an appearance of subhyaloid hemorrhage. The second picture is again not involving the center. The patient may end up having some amount of vision and may not come back to us at an appropriate time. The third picture, of course, with very blurry vision, the patient will come on time. But by the time he reaches this stage, or when the retina is pulled because of the tractional retinal detachment, he will definitely require a surgical treatment. So let's go on to our cases. The first case is a dilemma whether it is retinopathy at all. This patient is a patient who's a 55-year-old gentleman who came to our OPD with blurred vision. He's been a diabetic for past 10 years, going regularly for retina checkup. Sugars are well under control. He has been prescribed glasses recently, and his glasses read like for the distance +1, for the near according to his age +2.5. So when he came to us, we examined his retina, did a detailed slit lamp and biomicroscopic examination. We could not find any diabetic retinopathy, as you can see in this fundus picture. The physician was also concerned because the patient continuously was complaining of blurred vision. What happened in this patient?
As we probed his history, we found that he had a recent episode of uncontrolled glucose. He had gone in for an eye checkup to get a spectacle from a spectacle shop without mentioning his diabetes and was prescribed glasses. Then the diabetologist had a look, controlled his sugars. So what went wrong over here? The patient had taken his glass prescription in a hyperglycemic milieu. So at the time that he got his glasses made, the human natural lens in his eyes had imbibed more water and become more convex, giving the glass power a lower amount from his normal. So after that, he went back to his physician who controlled his sugars. So the previous glass power, which was a little lower than what he actually required, did not work, and therefore he had blurry vision. So both the physician and the patient got worried whether he had retinopathy. So once he came to us, it was at a time when the sugars were better controlled. It was 6 weeks or 8 weeks beyond the time that he had been prescribed glasses. There was no retinopathy, and we got the appropriate glass power for him. So at high sugars, one should not give him glass powers. At normal, when the patient came back to normal sugars, there was blurry vision. So the glasses should ideally be prescribed after good control of sugars, that is 6 to 8 weeks. So what do we do when we prescribe glasses? If the A1C is high, more than 7.5, or the RBS or PPBS is higher than 250, we do not prescribe glasses immediately. Instead, control the sugars for at least 6 weeks, because that is the amount of time that the lens dynamics takes for it to stabilize, and then we prescribe glasses. However, on the other hand, if the A1C is already normal and or the RBS is less than 200 milligram per deciliter, then we can of course go ahead, and there is no risk of myopic shift taking place, so we can easily prescribe the glasses for the individual. Now, the case number 2 is a tale of tight control. This is a lady who was 53 years old, diabetic for the past 25 years. Her blood sugars were well controlled. Fasting sugars were 84. There was blurred vision, and her vision was only improving to 612 N6 in both the eyes. Her vision, her fundus picture looked something like this. With control of sugar, she came back to us, and the fundus picture looked worse than earlier, and her sugars were better controlled. So it was a surprise. But over time, the retinopathy seemed to have settled. So what went wrong over here? So on further questioning, we found that she also had a recent episode of very high blood sugars, and her HbA1c was around 11. So she was aggressively shifted from an oral regime to a 4-time aggressive insulin regime, and because of which her already pre-existing retinopathy had worsened. But however, with time, the retinopathy seemed to have stabilized. So this is well substantiated from the multicentric famous DCCT control, that tight control of sugars can worsen the retinopathy. But however, this episode happens for a short term. So in the DCCT control, there were 2 arms. One was the intensive control and the conventional control group. So the intensive control group did have worsening, 13.1% did show worsening of retinopathy at 1 year stage. But however, at 18 month stage, both the intensive and the conventional control group did show stabilization of retinopathy. So what are the factors which are contributing to worsening of retinopathy? This is a very high initial blood glucose levels, very high initial HbA1c levels, and very tight A1c control done under the period of 3 month stage. So worsening of retinopathy with rapid glucose control should always be kept in mind if the patient comes back to us with blurred vision and uncomfortable vision. So the presence of pre-existing retinopathy should be kept in mind while giving a glucose regimen, and the magnitude of glucose lowering should be also kept in mind and should not be done very aggressively and not over a short term period. So what are the reasons why the retinopathy worsens? So one theory is the osmotic theory, like lens changes which are occurring to the human natural lens in a hyperglycemic environment. There are osmotic changes which also occur within the blood vessels, and they are the ones which cause leakage of lipoproteins and other substances into the retina, worsening the retinopathy. The other theory is the synergy theory, which says that the insulin and vascular endothelial growth factor both act synergistically to induce growth and proliferation and even oxidant stress. So how do we manage these worsened cases of retinopathy? There are no clear-cut guidelines. Manage as you manage any other retinopathy. Wherever possible, a wait and watch approach or policy would always help, and avoid being over-aggressive on control. And I would also like to say that you don't have to really get very aggressive or start the diabetic macular edema control or therapy to it unless the sugars are well controlled over a period of at least 1 month or 1.5 months. So case number 3 represents that of a macular edema. 45-year-old lady with diabetes existing for 15 years came to us with worsened vision, pedal edema. Her fasting sugars were 125, postprandial was 186, HbA1c was 7.1. She was on a regimen of insulin, metformin and pioglitazone. Vision in the right eye was 618, 910, and there were no lens changes accounting for this vision. So case 3, as you can see from the fundus picture, had lot of findings in the center of the retina. Lower down is a color representation of the optical coherence tomography. The white area shows that there is lot of fluid in the macula at the center, which is causing the vision loss. The picture to the cross-sectional picture to the right hand side, which shows a mountain, that is a retinal fluid amount, which is measured by OCT, and it represents around 643 in this patient. The normal retinal thickness is around 240 to 280 microns in the Indian eyes approximately. So why does she have so much of edema, and should we aggressively treat it? So before we embark on that, let's look at what this OCT actually has to tell us. OCT is a magic tool to us. It's an optical, the full form is the optical coherence tomography. It gives you a non-invasive in vivo view, cross-sectional view to all the 10 layers of the retina. The first picture represents the normal central dark area or the retina, where the perfect vision is formed. The second lower picture is a retina which has a pathology, which has diabetic macular edema, and the mountain represents the retinal fluid, which requires to be treated so that the vision comes back to normal. So we go back to our case number 3. So we looked at her regimen, and before we started the fundus fluorescein angiography and OCT on her, we went back to the patient and stopped her glitazone, then did her fluorescein angiography and found out which are the leaking areas of microaneurysm which required laser therapy. We also did anti-VEGF injections on her. So the management of case 3 was perifoveal laser, stopping the pioglitazone, which was most important because that will reduce the number of injections to this patient. So control of metabolic parameters, control of blood glucose, blood pressure, fasting lipid profile, altering medications of for sugars if the patient is on glitazone is also a very important factor in the management of retinopathy. So this is one of papers in a popular journal of retina, which showed that just stopping the glitazone improves the macular edema and improves vision in a substantial number of patients. Of 73, almost it was cured and did not require any further therapy. So the message from case number 3 is restrict usage of pioglitazones if there is pre-existing retinopathy along with macular edema. Case number 4 is that of a 30 poorly controlled sugars, presented to us initially in 2017 with moderate retinopathy changes. We asked him to come again to us every 6 months. He and came back to us with pictures like this with worsened retinopathy. We were about to tell him a regimen for retinopathy, but we found out that when we looked at his metabolic control, the blood pressures was 220 and 170. And once we controlled his blood pressures, the retinopathy also settled. So the role of metabolic control is emphasized once again with this fundus picture of another lady who came to us with her fundus picture looking like this. With adequate metabolic control and further treatment for retinopathy, her fundus picture looks almost near normal. So this is a chronology of events for the same patient who had retinopathy which was florid in the first picture in 2006. 2007 the vision did not improve much. 2008 the vision again did not improve much, but you can see in chronology the fundus picture almost looks near normal with just good metabolic control and counseling. So this importance of metabolic control is emphasized in most of the multicentric trials, which from the DCCT it says that the reduced incidence of diabetic retinopathy itself can occur in 76% of cases. UKPDS studies emphasizes that blood pressure control can reduce the need of laser in 1/3 of the patients. Accord study again says that reduced risk of retinopathy and progression can occur in 40% of cases. So the foremost important thing in management of retinopathy is the control of blood glucose, control of blood pressures, treatment of blood lipids if they are high are extremely important in management of diabetic macular edema. I summarize by telling you that management of retinopathy involves ABC or control of A1C, B for BP and C for cholesterol. If the vision threatening complications are again uncontrolled or they still require treatment, one could subject the patient to either optical coherence tomography and or digital fundus fluorescent angiography and then treat it, appropriate it with laser, anti-VEGF agents, which are a multitude of them. If the patient has gone beyond all this, it could be treated with surgery and then further follow-up. So this is another patient who who came to us with this kind of a fundus looking with florid exudates in the retina. He was treated with laser. This is fresh laser marks which you can see with a vision of 624. Over a period of time, the vision improved, the fundus picture also improved. So with good metabolic control and with treatment of retinopathy with perifoveal laser and anti-VEGF agents, we can have very gratifying results and the fundus picture can look as if there was never retinopathy initially. So case number 5 is a 61-year-old patient with diabetes for past 5 years with severe vision loss. Her HbA1c was 7. She was on metformin insulin. There were no other comorbidities. When we looked at her fundus picture, the disc was looking pale, edematous and something like this. So there could be other causes of vision loss when you are considering diabetic retinopathy. It could be papilledema due to hypertension. It could be anterior ischemic optic neuropathy, which should be kept in mind while treating these patients. Sometimes these are also confused with papilledema. So optic nerve changes or optic disc edema could also be there along with diabetic retinopathy and should be kept in mind while treating them. So I have summarized the treatment of diabetic retinopathy management in these 5 cases. So one should remember that all that meets the eye is not diabetic retinopathy. It could be a simple hypoglycemic milieu causing blurred vision, and appropriate glasses at an appropriate time after controlling sugars would be adequate. Always avoid very rapid lowering of great magnitude in pre-existing retinopathy. This could worsen the retinopathy. Case number 3, which should be kept in mind, if you have diabetic retinopathy already with macular edema, do not consider treating the patient for sugars with glitazone. Case number 4, always control the metabolic parameters before we encroach on to treating the retinopathy. Case number 3, there could be other atypical situations which lead to vision loss, and of course timely referral to the ophthalmologist. And we have in our armamentarium multitudes of laser, anti-VEGFs and surgery. All these are available in every nook and corner of the country. Thank you for a very patient hearing. Good evening, everybody.
Session, Dr. Savita. You have covered all the parts of retinopathy, and now I call upon Dr. Mahajan. Over to you.
Our next speaker is Dr. Charan Bale. He will be giving us a talk on non-proteinuric diabetic kidney diseases. Please display CV. Yeah. Dr. Charan Bale is a DM nephrology, consultant nephrologist and transplant physician at Chelaram Hospital, International Society of Peritoneal Dialysis Scholar, and his areas of interest are difficult access placements, chronic peritoneal dialysis, critical care nephrology, and CKD, diabetes mellitus. Over to you, sir.
Thank you, ma'am.
Good evening, delegates, chairperson, and all my colleagues. Today's my topic is non-proteinuric diabetic kidney disease. The overview of the topic, that will be terminology, epidemiology, literature review of diabetic kidney disease, and management of DKD. Diabetic kidney disease is a clinical diagnosis based on the presence of albuminuria, decreased estimated GFR, or both in diabetes patients. Notably, diabetic kidney disease does not indicate a specific pathological phenotype. Diabetic nephropathy was historically defined by the presence of albuminuria accompanied by retinopathy in patients with type 1 diabetes. So there is a 52-year-old female who is a known diabetic since 20 years, and she gives a history of fairly controlled blood sugars in 20 years. Currently the fasting is 138 milligram per deciliter, PP 208 milligram per deciliter. HbA1c was 8.3 in 2020 and currently it is 6.2%. Serum creatinine is 2.8, UACR more than 150 milligram per gram, and fundoscopy shows bilateral proliferative diabetic retinopathy. The diagnosis is straightforward, which is diabetic nephropathy, where we can see this KW nodule deposition in the glomeruli, and there is a mild mesangial expansion in the mesangial area. Diabetes is a leading cause of chronic kidney disease and end-stage renal disease in United States and worldwide. Prevalence of diabetes has reached epidemic proportions in the world. According to International Diabetic Federation, there were 366 million people with diabetes in 2011, and they're expecting the figure to increase to above 500 million in 2030. A Bohr et al. Study of diabetic adults, the prevalence of nephropathy was 34.5%. The prevalence of impaired GFR with or without albuminuria was 17%. And the plain prevalence of albuminuria without or with reduced GFR was 23.7%. Parve et al. Prevalence study shows that prevalence of albuminuria in a cross-sectional survey among 30,000 type 2 diabetic patients spanned around 33 countries. The overall prevalence of microalbuminuria was 38.8% and macroalbuminuria was 9.8% with racial differences. However, the 22% was only the patients with impaired GFRs. Diabetic nephropathy is the cause of diabetic kidney disease in type 1 diabetes of more than 5-year duration with albuminuria, but the frequency can range widely in type 2 diabetes, which diabetes kidney disease has been superimposed, or there can be a de novo non-diabetic kidney disease is present. Only a kidney biopsy can confer with certainty that diabetic kidney disease is due to diabetic nephropathy in type 2 diabetes mellitus. Kidney biopsy is seldom done in these patients. Now we come to a second case where there is a 60-year-old male known diabetic since 8 years and fasting currently is 124, postprandial is 182 and HbA1c is 6.7, which is fairly controlled. And it's good control for a creatinine of 2.1 and UACR of 272 milligram per gram. So looking at there is no significant proteinuria and there is impaired GFR and sugars are well controlled. So looking at this, where this patient fit in. Now we will come to the literature review of diabetic kidney disease. Despite this clear defined pathway, there have been increased reports in both type 1 and type 2 diabetes. A proportion of patients may have a renal impairment without significant proteinuria or albuminuria, advanced with stage 3 to 5 advanced kidney disease. Among 300 type 2 diabetic patients presenting to OPD in Australia, there were 39% of normoalbuminuric patients and 1200 patients from third National Health Nutrition Examination Survey of patients with GFR less than 60 ml per minute, which shows 36% of normoalbuminuria. Recently, a non-albuminuric renal impairment syndrome was described in type 2 diabetic patients, which had distinct clinical features that are not clearly associated with poor glycemic control and correlated less closely with retinopathy and high blood pressure. This entity is associated with high prevalence of cardiovascular disease. Therefore, predominance of macroangiopathy as the underlying renal pathology has been suggested. Now we come back to the same case with following light. So I just went in for further investigations like 24-hour urine protein, which came out to be 750 milligram per day, and fundoscopy, there was no retinopathy, and sonography showed normal kidney size. With this, the patient made his kidney biopsy in view of unexplained deterioration in renal function. The histopathological findings in diabetic kidney disease are normal, class 1 will be normal or near normal renal structure, where 41% had biopsies which were normal or showed mild mesangial expansion, tubulointerstitial changes or arteriolar hyalinosis. Typical diabetic nephropathy came to be a class 2, that is seen in 26%, which had diabetic lesions with an approximately balanced severity of glomerular, tubulointerstitial and arteriolar changes. This picture was typical of that seen in type 1 diabetic patients with obvious light microscopy diabetic nephropathy changes, which I showed you earlier, that is with KW nodules and some amount of mild mesangial expansion. Now we'll come to class 3, that is atypical pattern of renal injury, where 33% had relatively mild glomerular diabetic changes despite disproportionately severe renal structural changes in all possible combinations. The combinations are as follows: A, that is tubular atrophy, tubular basement membrane thickening, reduplication and interstitial fibrosis. B will be advanced glomerular arteriolar hyalinosis, commonly associated with atherosclerosis of large vessels, and C was global glomerular sclerosis. The biopsy of the case which I was suggesting came out to be, this is glomeruli which shows mild mesangial expansion, and then there is periglomerular fibrosis can be seen around the glomeruli, and there is some amount of tubular atrophy which is seen here, here and in these tubules, and there is expansion of interstitial matrix which can be seen, and there are some amount of fibrotic band, that is interstitial fibrosis can be seen. More can be seen over here. So then we'll come to the second picture, where there we can see the ATN part, that is tubular necrosis, and here what we can see is this is a afferent arteriole entering the glomeruli, and this is the efferent arteriole which is leaving the glomeruli, where we can see there is significant deposition of hyalinosis can be seen in the afferent and some amount of hyalinosis seen in the efferent arteriole, and there is interstitial matrix expansion with fibrosis can also be seen in this picture. The Karamori et al. Studied 105 normoalbuminuric type 1 diabetic patients with at least 10 years of diabetes duration that had a renal biopsy performed. Patients were divided according to two groups, that is the patients with normal GFR and or reduced GFR. Clinical and renal structural parameters were compared between these two groups. Glomerular structural parameters were estimated by electron microscopy morphometry. Out of 105 patients, 23 patients with reduced GFR had advanced glomerular region, but no KW nodules or were described, nor were sclerotic lesions. So like we saw in the last slide, compared with control values, glomerular basal membrane width was increased by 42% in normal group compared to low GFR group, which was showing 64%. Similarly, the mesangial part of the glomerulus was increased by 40% in normal group and 70% in low GFR group. Mesangial matrix was increased in 67% in normal group and 122% in low GFR group. The finding of reduced GFR was much more common among female patients with retinopathy and or hypertension were also present. This report confirms that reduced GFR occurs among long-standing normoalbuminuric type 1 diabetic patients and is associated with more advanced diabetic glomerular sclerosis and probably with increased risk of progression to CKD in the patients with diabetic kidney disease. Management of diabetic kidney disease, which will be dealt with these subtitles, that is optimum BP control. Severely increased albuminuria patients are treated with angiotensin inhibition. Good glycemic control. Type 2 patients were started with additional kidney protective therapy additional to hypoglycemic episodes, hypoglycemic function. This additional kidney protective therapy will be SGLT2 inhibitors and non-steroidal selective mineralocorticoid receptor antagonists. Blood pressure control, the combination of AC inhibitors or ARBs plus dihydropyridine or calcium channel blocker is often preferred. Non-dihydropyridine calcium channels or diuretics may be preferred in severely increased albuminuric patients. Combination therapy with both on AC inhibitor and ARBs or AC inhibitor or ARBs combining with direct renin inhibitors should be avoided in view of hyperkalemic episodes. Treatment with angiotensin inhibitions, there was 410 adult patients with proteinuria of more than 500 mg and serum creatinine of less than 2.5 mg are randomly assigned to two groups, that is captopril group, which where the patient received captopril of 25 mg thrice daily, or placebo group. At the end of 3 years, captopril reduced the rate of death or ESRD in 11 versus 21% and reduced the likelihood of doubling of serum creatinine, it's 12 versus 21%. Glycemic control target in patients with type 1 diabetes and DKD is ideally a HbA1c of less than 7%. Goal should be tailored to individuals, balancing the improvement in microvascular complications with a risk of hypoglycemia. Lifestyle modification, diabetic patient regardless of kidney disease should be counseled with healthy eating, regular exercise, weight loss and cessation of smoking. As these diabetic kidney disease patients have high cardiovascular risk, they have to be treated with statin. And the role of protein restriction is unclear in diabetic patients, as they will already been advised for low fat and a simple carbohydrate diet restriction. Data are conflicting as whether to protein restriction may slow the progression in diabetic kidney disease. SGLT2 inhibitors, that is canagliflozin, and renal events in diabetes with established nephropathy clinical evaluation credence trial, where canagliflozin of 100 mg once daily was started and the other arm was with a placebo group, where 4,400 diabetic patients with eGFR between 30 to 90 mg per minute and UACR of more than 300 mg per gram despite of having AC inhibitors or ARBs were included. At the end of 2.6 years, canagliflozin reduced the incidence of ESRD and reduced doubling of serum creatinine hospitalization of heart failure and cardiovascular death were also reduced. Dapagliflozin and prevention of adverse outcome in chronic kidney disease, that is DAPA-CKD trial, where 4,300 individuals with eGFR between 25 to 75 ml per minute and UACR of 200 to 5,000 milligram per gram were randomly assigned to dapagliflozin, that is 10 milligram once daily, or placebo. Out of 4,300 individuals, 2/3 of enrolled patients were type 2 diabetic, 98% were taking AC inhibitors or ARBs. At the end of 2.4 years, dapagliflozin reduced all-cause mortality and reduced the incidence of ESRD and reduced the risk of decline in GFR, that is, slowing the progression of the disease. Activation of mineralocorticoid receptor is associated with cardiovascular and kidney disease putatively by stimulating inflammatory and fibrotic cascade. So the non-steroidal MRA, that is finerenone, reduces albuminuria and has smaller effect on serum potassium. Finerenone in reducing kidney failure and disease progression in diabetic kidney disease trial. So where 5,700 patients with type 2 diabetes severely increased or moderately increased albuminuria plus retinopathy were randomly assigned to finerenone or placebo group, where finerenone was started with 10 to 20 milligram once daily. All patients who were enrolled were taking maximal or maximally tolerated dose of AC inhibitor or ARBs at baseline. At the end of 2.6 years, finerenone decreased the incidence of GFR and progression to ESRD. Both were reduced with this finerenone group. Hyperkalemia occurred more frequently with finerenone, where you can see that is the hyperkalemic episode is nearly double compared to placebo group, although only a small number of patients discontinued randomized therapy due to this complication. How to monitor these patients on OPD basis? So these patients are called for follow-up every 3 to 6 months, where we have to assess the blood pressure, volume status of the patient, eGFR based on serum creatinine, serum potassium levels, HbA1c, and an evaluation of urine albumin or total protein excretion in the urine. Prognosis of these patients: a substantial proportion of these patients will progress to loss of kidney function and will develop ESRD. The strongest risk factor which is associated with high progression to CKD or ESRD were the presence of increased albuminuria, reduced estimated GFR, and anemia. Thank you for being a patient audience. Thanks a lot.
Thank you for the wonderful presentation, Dr. Charan Bale. So there is a question for Dr. Panse. What are the choice of imaging modality that you use to detect foreign body injury in patient with diabetic foot presenting to you?
Mostly we'll do a X-ray of the foot, AP, lateral and oblique views. And if it is picked up on an X-ray, then additional ultrasonography just to see the depth from the surface of the skin. And if it's not picked up on an X-ray, then we go with ultrasound, and we can put a marker on the skin surface and measure the depth of the foreign body from the skin surface. Then these are the two main investigations we do. In very rare cases, MRI can be also be done.
Okay. So a question to Dr. Savita Bhatt. Can you please explain us about the late presentation of diabetic retinopathy and how can we delay the further progression?
So you mean to say proliferative diabetic retinopathy?
Yes.
So, as I told in my previous talk or discussion, every diabetic should be screened at least once a year. As the guidelines tell you, type 1 should be screened at least after 5 years, and type 2 at the time of presentation. So by doing that, we can actually delineate as to who has retinopathy or who does not have retinopathy. And those late presentations who come to us pretty late can be avoided. So if you do have retinopathy, like I told you from my previous talk, that the person need not be symptomatic. He may present late to us because he does not have any symptoms. So when patients actually do not realize that they have a problem in their eye, they don't come to us, especially in India, where the annual checkup or annual screening trends are not there. The other way to go about it is in physician's clinic, one could have these fundus cameras, which can cameras which can take non-mydriatic even without dilating the fundus. You can take pictures and it can be read either by an eye specialist, or alternately you have multiple artificial intelligence programs which can read out the retinopathy level itself. So by doing so, the physician himself can screen for retinopathy at an appropriate time whenever he sees any diabetics. The other option, which is much simpler to that person, is you refer to a local ophthalmologist and he will tell you by dilating or by taking pics whether there is retinopathy or not. And then you have to educate the patient and show the pictures so that the patient is actually aware that there is a problem in the eye and requires to be fixed. And more so, he requires to keep his sugars under control. So if the patient, the second part of the question is, if the patient presents to us late, what do we do? So if the patient presents to us late, there are several levels. And nowadays, there is a large multi-center trial, which is, we derive our conclusions from it. It is called the DRCR NET, or Diabetic Retinopathy Clinical Research Trial. And this helps us give us guidelines to how we should go about treatment. And some of the things which I presented are also substantiated from that. They tell you that when you have proliferative diabetic retinopathy, or when you have diabetic macular edema, you don't have to jump and treat it immediately. You can wait till the metabolic controls are achieved. When you have proliferative diabetic retinopathy and when you have a bleed in the eye, or you have a potential interface areas where you have neovascularization, those areas are likely to bleed anytime. So the sugar control or the metabolic control needs to be done simultaneously along with the physician's control of sugars. So you can treat it. It need not be that the sugar has to be absolutely controlled before you go on to treating it.
Thank you, Dr. Savita.
Thank you for your question.
So with this, we can close the session.
Thank you.
Thank you,
Thank you.
everyone.
Thank you, everyone.
Thank you so much.
We'll take a break for half an hour and then we will again continue at 5 p.m.
Okay, ma'am.
Good evening, all. Hello. Am I audible? Hello. We will continue after 10 minutes.
Hello.
Okay, ma'am.
Sir, we will start our session soon at 6:05.
Yes, that's fine. You can hear me?
Yeah, yes.
Yeah, okay.
Thank you, sir.
So my video, I'll just turn it on. Is that okay or anything needs to change?
Yes, sir.
My video is okay. You can see the video?
Yeah, yes, sir. Yes, sir.
Yeah, okay. Fine.
Hello everyone, good evening. Now we are starting our next session regarding diabetic foot ulcer. Before that, I would like to introduce our chairperson, Dr. Mansi Haral. CV please. Dr. Mansi Harare has done MBBS MD medicine from BIGMC College, Pune. She is consulting physician at Supreme Clinic. She is associate professor at Dr. D.Y. Patil College, Pimpri. She has publication in national and international journals. Our next chairperson is, next slide please. Dr. Amit Nighate. His CV please. Okay. He has done his DNB family medicine. He is PGP in diabetology from John Hopkins University. CCD in diabetology. He has PG certificate in diabetic foot management AIMS. He has fellowship in diabetic foot care and wound care JIVAS. He is consultant diabetic foot. He is consultant at diabetic foot surgery Kamal Nayan Bajaj Hospital, Aurangabad. I'm over to you, Dr. Mansi Harare.
Thank you for the kind introduction. The next slide, please. Our speaker for today is Dr. Amrish Bideye. His MBBS is from Bharati Vidyapit Medical College. He is MRCS UK and FRCS Trauma and Orthopedics. Fellowship in Foot and Ankle Surgery, and he's a consultant foot and ankle surgeon at Chilaram Diabetes Hospital. He'll be now speaking on diabetic foot ulcer. Over to you, sir.
I'm going to talk to you about a couple of case studies from our institute about diabetic foot ulcers. So case one was a 50-year-old male who was a type 2 diabetic. He was newly diagnosed type 2 diabetic. So he got a wound on his right foot, for which he tried traditional home remedies with hot dough. Later on, he soaked his foot in water containing potassium permanganate, and this made things worse. Once they got worse, he presented to one of the other hospitals, and this was during COVID times. So he was not taken to theater, but he had a series of debridement done of that abscess on the dorsum of the foot in the ward. Things got worse sort of day by day, and he started getting very sick. So he took discharge against medical advice from the other hospital, and he presented to us. Before he came to us, he also had visited a few other surgeons, including plastic surgeons, who had all advised him to undergo a below knee amputation. So this is the wound that he had. This is the photo from one of the outside hospitals. So he got this infection on the dorsum of the foot, and this was one of the debridements that was done. And this is this is when he presented to us. So you can see this big wound on the dorsum of the foot with cellulitis up the shin. You can also see some blisters at the back here and degloving sort of injury on his, that is, I think, on the lateral side of his foot. So he had his bloods done, and he was obviously septic. He was really unwell. He was pyrexial. His hemoglobin was 8.3. His white cell count was 18,000. CRP was 47. And low sodium, slightly raised creatinine, and a very high HbA1c. So this guy actually did not know that he was diabetic until this particular episode. And this is one of the scoring systems that we'll come to later, which is a laboratory risk index for necrotizing infection score. Okay. And his score was 10 as per these markers. These are the markers that are used, and his score was 10. More than 8 is considered to be highly suggestive of necrotizing fasciitis. So his cellulitis was still about mid-calf to high calf region, and by the time we got to him, his forefoot was completely gangrenous. So a decision was made to take him to theater as an emergency for debridement, plus he was definitely going to lose the forefoot, so a transmetatarsal amputation was planned, but we had also kept the backup of a below knee amputation ready in case we found things really bad. Intraoperatively. So when we went to the theater, the part was moved, which was you can see the metatarsal heads here. So the front part of the foot was removed, and all the skin that was on the dorsum of the foot moved. So the incision extended proximally, as you can see in this wound, and a lot of the subcutaneous fat, as you can see up here, were really horrible. They were all sloughing off. However, the underlying muscles that you can see here were actually not affected. So we opened muscles, and there was no pus in the muscle belly. Above the muscle layer, everything was really bad. And as you can see, if we have videos of this, you can see this, we were pressing, and you can see this pus coming out this is from the laterals, this is from the of the foot. So all of the tissues were removed. Some of the skin which was borderline for some reason, okay, at the moment, try a different network. A couple of cases regarding diabetic foot ulcers from our institute. Okay, so case one is a 50-year-old male who is newly diagnosed type 2 diabetic. He had a small wound on his right foot, which he sustained at home. I think he hit something on his foot. So initially he tried traditional home remedies with hot dough, and things got worse. So he soaked his foot in water containing potassium permanganate, which made things even worse. So he got worse and presented to one of the other hospitals. This was during COVID times, and he couldn't actually go to theater. So they did a series of debridements on the dorsum of his foot. Initially, I think on the ward, and once they took him to theater. So things got worse and worse, and he became septic. So he took discharge against medical advice from those hospitals, and he presented to us. So before he presented to us, he asked multiple other surgeons about their opinion, and including plastic surgeons, and he was advised to have a below knee amputation for this. So this is his wound. This was actually in one of the outside places that this photo was taken. And when he presented to us, he was like this. So he has a big wound on the dorsum of his foot. His toes are started getting dusky. You've got cellulitis going up sort of nearly half his leg up. And out here, you can see blisters and burst blisters out here on the posterolateral aspect of his leg. So he was really septic. He was really unwell, pyrexial. His blood showed a HB of 8.3, white cell count of 18,000, CRP 47, creatinine slightly raised, sodium slightly decreased, and a very high and uncontrolled HbA1c. So this is one of the scoring systems that we use. It's called a laboratory risk index for necrotizing infection score, and that it is based on these markers that you have on the left here, and the score was 10. If you have a score of more than 8, then it is considered highly suspicious of necrotizing infection. Okay, so cellulitis was till about mid calf. His forefoot after that picture actually became completely gangrenous. So we took him to theater as an emergency. He was posted for debridement, plus we were definitely going to do a transmetatarsal amputation, but we had also kept a backup of a below knee amputation ready. So these are some of the intraoperative pictures. So this gangrenous part was removed. As you can see, these are the metatarsal heads. So the part ahead of it was completely gangrenous. The skin and tissues on the dorsum of the foot, which were really infected, were removed. Then this incision was extended proximally. And as you can see, most of the subcutaneous tissue, fat, everything was really bad and infected, and as was the overlying skin. However, the muscles underneath were actually not bad. We even opened them up, and there was no pus in the muscles. So these were when you pressed along the wounds and you got a lot of pus discharge from the subcutaneous tissues. We had a good video of this, but I've got a couple of photos here. So what we did was we removed all the infected tissues, which was mainly the subcutaneous tissues and the skin. Some of the skin which we felt was borderline, but was in the important areas like covering of the tendo Achilles posteriorly, we conserved. We sent all of the samples that we sent for culture, and culture sensitive antibiotics were started. Post-operatively, immediately his medical condition. So initially, obviously, he was on broad spectrum antibiotics, and culture sensitive antibiotics were started after we got the results, which was after a couple of days. However, even before that, his post-operative condition really improved, and he was out of ICU in a few days. Daily wound inspections and dressings were done on the ward. This is actually one of his first photos, which still looks really bad. So this border skin we actually preserved. This was a layer of skin on the tender Achilles that was conserved. This was at the transmetatarsal level. His actually the sole was pretty good. The sole of the foot was pretty good, the plantar surface. Okay. But you can see here the edges are a bit dusky. Here also you can see slightly dusky even at this edge. So some of the skin that was preserved did become necrotic and they were debrided. So you can see this skin out here became necrotic. The edges here became necrotic, as did the bridge that we had left over the tender Achilles. So they were all removed. And you can see here, he's actually even, one of the good things was that his blood supply was pretty good. So he still has a little bit of necrotic tissue at the edge, but the rest of his wound had already started looking healthy. Good granulation had started coming. Even some of it had started covering his tender Achilles posteriorly. He was managed by our podiatrists with regular OPD dressings. He was discharged home. Wound continued to improve, and he came to a stage where whole of it was covered with really healthy granulation tissue, which was ideal for grafting. And you can see that here. Excellent granulation tissue all over. Full wound, even posteriorly, just a small spot here that also got covered later on. But the patient declined any further operative intervention at this stage. He'd had multiple surgeries and he had exhausted his financial resources, and he did not want any further operative intervention. So he agreed for regular follow-up in the hospital, and hence we continued to manage him conservatively with regular dressings using local agents. Later on, we added epidermal growth factor creams as well. So this is at the end. So you can see very good plantar surface. Wounds have almost healed. This is without grafting or anything. And he's soon going to get a shoe fitted and he will start mobilizing soon. He's got, this is also an old photo. So now there is just a very small spot left here, okay, which is going to get covered very soon. So he'll soon be walking. And all of this wound, big wound, is healed, and he managed to avoid a below knee amputation in this case, and he managed to sort of get away without any major morbidity or mortality. So this was a case of necrotizing fasciitis, which is a very rare but life-threatening infection. It has got very high morbidity and mortality. The infection spreads rapidly along the subcutaneous planes. The diagnosis is always clinical and it needs a high index of suspicion. The markers and everything that we use are used as a adjunct, but always the diagnosis is clinical. Early surgical intervention really helps in rapid improvement of the patient and restricts morbidity. So I think if we had waited for another day or two, we might have had to do a below knee amputation. Okay. And they always need repeated debridement. Sometimes plastic intervention is really helpful. I think this man, if he'd had the plastic surgery earlier on, he would have healed, I think, probably at least a month ago. Okay. So then next we're coming to a series of cases. So these are very small cases, and I've got just some pictures about these. So this year we actually had a pretty cold weather. We had multiple patients who presented to us with thermal injuries. So we've got a little series of those. So thermal injuries can be because of various modes. It can be direct heat, hot fomentation with hot water bag, walking on hot surface. Even ice packs can give rise to a thermal injury, and exposure to snow. So case number one is this 60-year-old male who's type 2 diabetic. He's known to have peripheral vascular disease. He went for a holiday in Kashmir, and it was extremely cold and snowing outside. So he sat next to a fire with his feet under a hot vessel. He did not even feel anything until he saw these blisters, pretty bad blisters on his big toe and his second toe. and they got infected. Then he came back to us to Pune, and he needed admission, IV antibiotics, regular dressing, offloading, and the wounds have gradually improved. I mean, the cellulitis and infection has all gone, and he's now left with very small wounds, but they're still not healed. So it's 2 months. So he's coming up to a stage where he is going to heal now. You can see proximally these wounds have started healing. He had these small scars over where his blisters were, but they are getting much better, but not yet. Another patient, 52-year-old lady, type 2 diabetic. She sat near a campfire, again in the cold. She got a blister which got infected. As you can see, when she came to us the next day, pus coming out of here. So this was deroofed. This blister was deroofed, and she needed offloading, regular dressings, and antibiotics. And her wound has completely healed. I think it didn't take her too long for this. This is another lady. She is 55-year-old, type 2 diabetic. She was walking for her diabetic exercise on her hot terrace barefoot, and she got a really bad ulcer here, and it was very deep and infected. I had to take her to theater to debride this. This was debrided in theater, and she needed regular dressings, strict offloading, and her wound, as you can see, has completely healed. But it again took her, I think, almost 3.5 months for this to heal. So thermal injury is common in diabetic foot. Most patients have got peripheral neuropathy. They do not feel this excess heat or cold. They also have some form of vasculopathy generally, which is why wounds take a long time to heal. So the best thing is prevention. So we need to educate our patients not to use hot water bags or even ice packs. You have any small injury, ankle sprain, something, we always tell people you use ice pack. So if the patient is diabetic, you should really avoid it, because that can lead to all of these problems. And once they get these injuries, it takes a long time to heal. Also, when they're walking, you ask them to avoid walking barefoot, especially on the terrace. They want this vitamin D, so they want to walk in the sunlight. And we've had quite a few patients who've had these thermal injuries on their feet. Okay, and also hot water bags are also to be avoided. Okay, thank you very much. That was my last case. Thank you.
I see no questions. Sir, what do you think about negative pressure wound treatment? Do we actually use it in your setup?
Yes. Negative pressure really helps to get the wounds to heal much faster. So it is a very good adjunct that we have to for wound management, and it really works, and we use it quite a lot.
Okay.
However, sometimes these patients who've had repeated infections and surgeries, so this patient that necrotizing fasciitis just couldn't afford anything after a while. So we just managed it, and as you can see, even without any fancy surgery further, like plastic covering or negative pressure or hyperbaric oxygen, his wound did get better. It just takes time.
Yeah.
Nice crisp presentation, sir.
Hello,
Dr. Amit here.
Hello, Amit. Thank you.
Hi. Which ointment have you used for the necrotizing fasciitis?
So in the end, after we were absolutely happy that he has no infection left and everything was much better, then we used Regen D.
Okay. And before that?
So before that, he was having dressings with initially with what did we use? Just normal saline okay. Dressings.
Okay.
And if there is a little bit of infection, I use something with a little bit of silver, like silver gel.
Yeah,
even
silver
hydroheal.
gel, silver collide or hydroheal or something sort of.
Yeah.
Yeah. what I would have used in this case would have been a pepinuria based ointment. That would pepinuria.
Okay.
That would have helped for going with your chemical debridement, as well as it would have helped to heal it up also. So I've seen both the results with that.
Okay.
I preferably used autolyze or debridase.
Debridase, yeah.
Yeah.
So now afterwards, this guy initially we did use debridase in him.
Okay.
But he had the good thing about the necrotizing fasciitis patient was he had very good blood supply. So
yeah, that's the main thing which we need.
Yeah. So he developed that granulation tissue so quickly afterwards. After we had done the surgical debridement, there wasn't much of slough to remove. It just needed covering up. So I think the creeping granulation tissue just covered it up. So we did use papin earlier. So we used a little bit of debridase, maybe for a week or two, but after that it was just not required.
Yeah, agreed. Once the slough is gone, then something to get more granulation.
Yeah, correct.
Regen D or something sort of. Yeah,
Correct.
That is the main thing.
So even after Regen D and using everything, it still took a lot of time for it. So, but
yeah, it's a huge bed actually to come up.
Massive.
Yeah, it was a massive bed. I'm having one with me right from below knee. Complete circumference is gone, including the TA and the dorsum.
Yeah.
I'm currently working on it.
Yes.
It's nearly 80% healed. TA is around 20 or 30% left. The TA was completely exposed. It was the fibers were completely exposed.
Yeah, same thing. If you saw, then I
saw it. I've seen it.
Exposed, but I was very surprised that this granulation grew over it so quickly.
Yeah, that's
without
the main
anything
thing.
else. So
yeah. That was a great thing.
Yeah. So yeah, so they just need regular follow up and good wound management, and if you do that, the wounds, if you've gotten rid of the infection, the wound will heal. It just takes time.
Yeah. I would like to ask, which kind of offloading device have you used for the midfoot ulcer? The thermobun with the lady which was walking on the terrace.
Or the midfoot ulcer. So initially, I just kept her completely, non-weight bearing. So once it got slightly smaller, then I used the anterior ortho wedge on her.
Okay. Anterior helped him?
Yeah, helped her.
Okay. And for not weight bearing, what a posterior slab was given or a bed rest was given?
Nothing. Just she had a walker, but she was walking, completely non-weight bearing on it. So
okay. That was good. Fair enough.
So again, so as I in my experience, all wounds will heal as long as they have no pressure on them, good blood supply, and you've gotten rid of the infection. So if these three factors are there, all wounds will heal.
Definitely. That's the main thing.
Yeah.
That's the main thing. This is what we all say is actually that once you get if a person or a individual walks to your OPD with an ulcer with the same footwear, and if you ask if that same individual leaves your OPD with the same footwear which has caused him ulcer, it's not going to heal.
Yes. We have not
this
done
is the
your
same
job
thing.
then.
Yeah.
Yes.
Overall, nice case presentations.
Okay. Thank you.
Sure. Do we have any other questions?
No, not in the chat box. No other questions.
Sure. So we can conclude that?
Yes.
Sure.
Okay. Thank you, Amit. Thank you, Dr. Hagar.
Sure. Thank you.
Okay.
Thank you. Bye-bye.
Bye.
Thank you.
Good evening, everybody, and welcome to this next session on hypothyroidism. Am I audible?
Yes, sir, you are.
Yeah. So, welcome to this next session on hypothyroidism, and for which, again, we have Dr. Mansi Harale as the chairperson to continue from the first session. So, I would request her to introduce the speaker, Dr. Beena Bansal, and we can then start the session. Over to you, madam.
The slide, please. Dr. Beena Bansal is the next speaker. She is MBBS, MD Medicine, and DM Endocrinology. She is founder and director of Door to Care and president of Saksham, Type 1 Diabetes Welfare Society. She is former director endocrinology of Medanta, the Medicity. She has research and publications in hypocalcemic cardiomyopathy, polycystic ovarian syndrome, premature ovarian insufficiency, and so on. Over to you, ma'am, for the topic for today, hypothyroidism in women. Thank you.
Good evening, everyone. I'm Dr. Beena Bansal. I have a clinic called Door to Care, an endocrine and diabetes clinic in Gurugram. And I am very happy to be speaking on a topic, hypothyroidism and women's health. I thank the organizing team to give me this opportunity because women's health is something close to my heart. We all know that hypothyroidism is very common in women, at least 10 times more common than men. At different stages of life, hypothyroidism affects women differently. For example, if it begins before puberty, it can cause both delay in onset of puberty, which is a more common presentation, but paradoxically, sometimes it can also result in precocious puberty because of a spillover effect of TSH on other receptors, gonadotropin receptors, because all of these are glycoproteins. After puberty, there can be many disturbances, specifically in menstrual cycles, for example, oligomenorrhea, amenorrhea, polymenorrhea, and menorrhagia. Again, because of impact on hemostatic molecules, and also sometimes excessive bleeding can be due to estrogen breakthrough secondary to anovulation. So these are some of the presentations which we see in adolescent girls. So that's an impact which affects them. As we can see, oligomenorrhea and amenorrhea is oligomenorrhea is quite common. 67% of girls in this study were affected by oligomenorrhea, which improved rapidly after levothyroxine therapy. However, rarely hypermenorrhea or menorrhagia can also happen. More importantly, thyroid affects women in reproductive age group, and subfertility or infertility may be a manifestation. And one of the most common clinical interactions which we have in our clinics is when women planning infertility management come to us. And there are a lot of dilemmas which I'll just summarize in short. I'm not going into the details of the controversies with TSH cutoffs and antithyroid immunity impact on fertility. So to start with the case, a 28-year-old female who presented with infertility doesn't have a history of hypothyroidism. So is it required that we routinely do a thyroid function? And if yes, which test? So we now recommend thyroid function in all cases being evaluated for infertility. The TSH in this woman came as 8. So the diagnosis I have written overt hypothyroidism because in the reproductive age group, the cutoffs for defining subclinical and overt are little different. So TSH more than 4 is almost overt hypothyroidism from fertility and pregnancy point of view. So TSH more than 8 is something which more often than not we treat. So we can have someone presenting with a TSH of 8 getting treated for infertility. What would be the consequences of starting levothyroxine, how that will help in this case, that we'll discuss, or vis-a-vis someone who presents with a TSH of 4, which is subclinical hypothyroidism, 4 or 3. And if it is 4 or less than 4, are any other tests needed? And will levothyroxine therapy improve fertility, and should we start levothyroxine therapy? So I'm just putting in some of the questions because these are the common presentations in our clinic. Summarizing the guidelines based on various trials which we have, it has been seen that TSH more than 4, levothyroxine therapy has been shown to improve pregnancy rate and live birth rates, and levothyroxine treatment is recommended in this group. In all women desiring pregnancy. Also, during pregnancy, we want to control TSH to less than 2.4. Therefore, the recommendation clearly to start levothyroxine therapy if TSH is more than 4. TSH 2.5 to 4. If the TSH is in this range, which is upper part of the normal range, then we test for antibodies, and if antibodies are positive, then we start levothyroxine therapy. If TSH is 2.4 to 4 and antibodies are negative, there are no clear recommendation to start levothyroxine therapy, and the treatment has to be individualized, taking into account the patient's history. However, more often than not, there may not be much benefit in treating this group. And someone who has a TSH of less than 2.5 and antibodies are positive, anti-TPO and anti-TG antibody, then again, although we know the relationship between anti-TPO antibody positivity with subfertility, levothyroxine therapy may not help in improving the symptom. So this is, it's recommended to check TSH in all women desiring pregnancy. Also check women in all women undergoing artificial reproduction therapy, ART. Again, if TSH is more than 4, we start treatment. We start levothyroxine in 25 microgram to 50 microgram, depending on the weight of the patient. TSH 2.5 to 4, if antibody is positive, then also there is a clear recommendation in this group of patients to start levothyroxine therapy. TSH 2.5 to 4, but antibody negative, even this group may benefit from levothyroxine therapy, specifically in patients who are undergoing treatment for infertility or subfertility. TSH less than 2.5, if antibody is positive, there are no clear recommendations to start levothyroxine therapy, but one may consider that, considering that it may not harm the patient, but the benefits may not be there. So that was about fertility and hypothyroidism. Once a woman is pregnant, again, there are a set of recommendations. Pregnancy is a special state where thyroid metabolism changes in many different ways. Number one, there is an increased demand for thyroid hormone in pregnancy, which is partly taken care by thyrotropic stimulation by HCG. This stimulation by HCG can change thyroid hormone profile or the measurement of TSH, especially in the first trimester when HCG levels are high. So that is important to remember, because TSH may go low normally also in first trimester of pregnancy, something which is called as HCG-induced thyrotoxicosis. The iodine requirement of mother is increased in pregnancy. So it's important that there is no iodine deficiency, and sometimes dietary good intake is required because of increased maternal dietary iodine requirements. There is also increased renal clearance of iodine. While analyzing the thyroid function reports, it's important to remember that estrogen causes increase in thyroid binding globulin in systemic circulation, which means that total T3 and total T4 levels will show much higher values as compared to a non-pregnant person, and the cutoffs for T3 and T4 change during pregnancy. Sometimes we recommend checking free thyroid hormone and free T4, but there are issues with the assays in during pregnancy, and unless we are very sure that the assays are really reliable, it's better to check total T3 and total T4 and keep a higher cutoff. So this is about changes in thyroid metabolism during pregnancy. The other important thing is that we know that T3 and T4 cross placenta and reach the fetus, and thyroid hormone is very important for fetal brain development. What this table is showing is that in the first trimester, while the fetal gland formation is still going on, it's the maternal thyroid hormones which takes care of the fetal thyroid hormone requirement. In the second trimester, it's both a combination of maternal and fetal. So second and third trimester, it's a combination of maternal and fetal thyroid hormone. But in the first trimester, it is exclusively maternal thyroid hormone, which helps in various stages of neurodevelopment, neuron proliferation, onset of neuron migration, cortex, hippocampus, cochlea. So we can see that the neuronal development can be affected by thyroid hormone deficiency, by maternal hypothyroidism, and hence that is what we see in various clinical trials also. So if a pregnant woman, this is another common case which we see in our clinics in gynec and endocrine clinics, a 12-week pregnant female coming with a TSH of 20 and free T4 of 0.6 picogram per ml, which is clearly a case of overt hypothyroidism. And we want to understand what is the effect on fetus, what is the effect on pregnancy, and how is levothyroxine replacement going to help her. So from various trials, it is clearly established that overt hypothyroidism with increased fetal distress in labor, prematurity, low birth weight, breech presentation, cesarean section, and increased risk of IUGR and fetal and perinatal deaths. The percentage increase is anywhere from 10 to 20% in these fetal complications. Even with subclinical hypothyroidism, a range much less than that, Haddo et al. Had shown that hypothyroidism untreated versus treated, there was a difference in IQ score, which was 7 points lower than a baby which was not affected by maternal hypothyroidism. So chances of having IQ score less than 85 is increased to 19% in fetus affected by maternal hypothyroidism versus 5% in a normal fetus. So there is psychoneurological impact of hypothyroidism in the progeny, which improves with levothyroxine treatment. So this is a very clear benefit of treating hypothyroidism. So that was the effect on fetus. Effect on mother is that there is an increased risk of preterm birth. Preterm delivery risk is increased, and when we give levothyroxine, the risk is reduced. There is also an increased risk of preeclampsia, placental abruption, and miscarriage, which all have been shown to improve with levothyroxine therapy. So overt hypothyroidism needs to be treated because there are clear benefits. What about slightly lower levels of TSH? So even subclinical hypothyroidism has been shown to be associated with miscarriage. Early and very early pregnancy losses have been shown to be associated with subclinical hypothyroidism. Even lower TSH, 4 or TSH less than 4, which is euthyroid high normal, Do we need some more investigation? If it is euthyroid high normal, then we go for anti-TPO antibody. And it has been shown that euthyroid, TSH in euthyroid range, but anti-TPO positive has been associated with increased miscarriage rate. So a meta-analysis, this was a 2010 meta-analysis, and a more recent meta-analysis also established clearly increased risk of miscarriage and preterm delivery with anti-TPO antibody positive and a TSH in the upper range. So what do we do if a lady presents with us with hypothyroidism and with euthyroidism, but TSH between 2.5 to 5? So pregnancy loss has been shown to be higher if TSH is 2.5 to 5 versus TSH less than 2.5, even if the lady is TPO negative. So there is increased risk of pregnancy loss, but whether this group benefits with levothyroxine therapy is not clear. So as we discussed, TPO association with miscarriage is clearly shown. TPO positivity is associated with preterm delivery, and this table shows at different levels of TSH. So reference range is TPO antibody negative women. TPO antibody positivity is associated with preterm delivery, even if thyrotropin level is within normal range. TSH 2.5 and above also there is increased risk of preterm delivery, and the TSH more than 4, again that risk is there. So we can see that early and very early preterm birth is associated with anti-TPO positivity, even with a normal TSH level. Unfortunately, treating these women may not help in improving the prognosis if TSH is normal. So levothyroxine therapy, when we introduce levothyroxine treatment in women who have thyroid autoantibodies, it doesn't help in reducing the risk of miscarriage. So although there is an association with miscarriage and preterm delivery in women with thyroid autoantibodies, the risk doesn't go down with levothyroxine therapy if TSH is normal. So similarly, if TSH is 2.5 or less, we already discussed. How do we, if a woman is a known case of hypothyroidism already on levothyroxine, say she's taking 100 microgram of levothyroxine and her TSH is well in control, 2.5, and she's planning conception. So number one, I think she can go ahead with conception, but do we increase thyroxine even before TSH increase? So there was a study in which there were two groups of women. In one group, there were 2 additional tablets of levothyroxine were given every week. So the women, she continued to take, in this group, they continued to take 100 microgram every day, but twice a week, they would take 200 microgram. And in another group, thrice a week, they would take 200 microgram. So the risk of thyrotoxicosis was higher in women who were receiving 3 additional tablets. In women who were receiving 2 additional tablets, that was not significant. So 2 additional tablet, even with 2 additional tablet, there were 2 women who had a TSH more than 5 at 14 to 16 weeks. So TSH does tend to creep up during pregnancy, and therefore giving additional tablets, additional dose from the very beginning of pregnancy is what is recommended, with TSH testing every 4 weeks. So in hypothyroidism in pregnancy, number one, we check TSH in all pregnant women, irrespective of symptoms present or absent. If TSH is more than 5, we clearly start treatment, even more than 4. TSH 2.4 and antibody positive, there is an indication to start treatment. TSH 2.5 to 5, antibody negative, one may consider treatment. TSH less than 2.5 but antibody positivity, levothyroxine treatment doesn't help. So to end the whole presentation, we discussed about adolescent girls, we discussed about women in reproductive age group, those with subfertility and infertility, and those who present to us with pregnancy. It's important to also focus on postmenopausal women. Number one, with increasing age, the risk of hypothyroidism and thyroid autoimmunity increases, and the percentage of menopausal women who would be affected by hypothyroidism keeps on increasing with age. And there is an association of high TSH with cardiovascular risk. Both heart failure and CAD has been shown to increase with increasing TSH, especially beyond 10. Hence, it is important to focus on hypothyroidism also as a risk factor for cardiovascular disease and keep a watch on that. However, in elderly people, we tend to undertreat rather than overtreat. So, thyrotoxicosis may be harmful, and therefore one may not want to start treatment if TSH is less than 10, only when TSH crosses 10. In the last few minutes, I want to just put forward some questions, which again we encounter very frequently in our clinics. Recently, I had a lady who was being treated for hypothyroidism, and her TSH has always been normal, but she still went on having persistent symptoms. She was feeling tired all the time. The weight was not going down. There were depressive symptoms. For us, it is very difficult to understand whether all these symptoms are related to hypothyroidism or they are because of some other associated comorbidities or associated depression. There is more and more evidence that despite a normal TSH, patients may not be feeling completely normal, and therefore it puts forward a question whether TSH is the adequate way of knowing whether a person is euthyroid or not. Is normal TSH always equivalent to euthyroidism? Dissatisfaction with treatment is very commonly reported. In various studies, it has been shown to be more in women than men. And very often there is dismissal of symptoms of women, and that's the main reason why they feel dissatisfied. In one of the studies, the more number of physicians the lady visited, more was the dissatisfaction. However, the exact reason is not clear. Maybe it's the autoimmunity affecting the body. Maybe it's because there is tissue hypothyroidism. Maybe because of altered T4 is to T3 ratio, which is seen in patients who are only replaced with levothyroxine. And therefore, there is a recent discussion on whether there is an indication for a combination T3 plus T4 therapy in patients who continue to have symptoms of hypothyroidism. It's still not clear whether that will help. In fact, there was a study which even showed that desiccated thyroid extract was also more effective than T4 alone for symptomatic improvement. So studies are still ongoing, and one would have to wait and watch what the final verdict will be. Also, the role of selenium in pregnancy. We understand that selenium is required for formation of selenoproteins and especially deiodinase. And therefore, selenium deficiency has been associated with a lot of complications in pregnancy, like preeclampsia, miscarriage, and the same symptoms which are associated with hypothyroidism. However, selenium has a very low threshold for toxicity also. And as of now, selenium supplementation in pregnancy is not recommended. It's important to just focus on healthy nutrition. So as there is still some ongoing studies on this. With those questions, ultimately with the focus that treatment has always, it should always be patient-centric, and sometimes we may not be able to take care of all the symptoms, but it is still important to listen to all the symptoms. And hypothyroid patients is one group of patients who really present sometimes with more symptoms than biochemical abnormalities. So we should stay away from getting too fixated on biochemistry, because with time, new therapies and new problems evolve, and therefore keep keeping our minds and ears open to all the symptoms the patients have to tell to us. With that, I end my presentation. Thank you.
Thank you, ma'am, for the excellent talk. I'll just see whether there are any questions. There are no questions in the chat box. What I would like to discuss is there are many women who are on treatment with levothyroxine. They have a normal TSH and they come to us with menorrhagia, polymenorrhea, oligomenorrhea. Does doing anti-TPO antibodies in this woman have some role?
I don't think that will help treat those symptoms. I think we still need to go for symptomatic management of those menstrual disorders if TSH is normal. Measuring anti-TPO, because we won't be able to treat that. We don't treat anti-TPO. We don't give steroids. That's not an indicated management. So sometimes the role of anti-TPO is mostly limited to where to initiate treatment. That's I think the most important roles for menstrual disturbances. It may not help.
And what about women who may be euthyroid and not on treatment? Does anti-TPO antibodies doing that in those women help?
We are getting so many people who come with anti-TPO antibody positivity with very high levels, scared of, anxious of the report. So I think doing anti-TPO antibody test is adding to a whole pool of anxious people, because we are sometimes not able to do anything about it, especially if TSH is normal. So as I said, if TSH is slightly high and we are not sure whether to initiate medication or not, anti-TPO helps, because people who have anti-TPO positivity, the risk of progression to overt hypothyroidism is much higher as compared to those who are anti-TPO negative. So that's a clear-cut indication of anti-TPO antibody. And also in pregnancy, there are implications because pregnancy outcomes may be affected. Apart from that, if we have a suspicion for other autoimmune disorders and we want to screen for that, we can as well check anti-TPO antibody. I think these are the main clear-cut indications. If we check an anti-TPO is positive, then what do we do with that? This would be a challenge.
No, I actually meant when the TSH was about 2.5.
In pregnancy.
Between 2.5 to 4, such a lady comes to me who is not on medication and comes to me with menstrual abnormalities. How do I approach her and how do I counsel?
Right. So 2.5 to 5 is a special group for people who are undergoing fertility management and pregnancy. Apart from that, 2.5 to 5 and anti-TPO positive, we will consider them as euthyroid, not requiring the euthyroxine medication, if that answers.
Thank you.
So there was a study in which subclinical hypothyroidism and subclinical hypothyroidism were treated with placebo and levothyroxine. Those who had normal T3, T4 and TSH less than 10 specifically for symptom improvement. So whether thyroid associated symptoms improved. And they did not find much difference between the placebo group and the thyroxine group, confirming that much of the improvement might be happening just because of placebo effect in this group where T3, T4 are normal and TSH is less than 10. So symptoms wise, if the patient is symptomatic and we want to check if it's anti-TPO antibody positivity will influence, I mean, whether to initiate treatment in them based on anti-TPO, I don't think that will help.
Considering older women, actually in old age as such, we keep the cutoffs high for the TSH to treat. But having a high TSH implicates greater risk for cardiovascular diseases. So how do we approach that? Should we look at the lipid levels, and if they are high, we treat it only with statin or add a low dose of levothyroxine? So how do we approach that?
So in women with hypothyroidism, we should definitely take care of overall risk management for heart disease, including statins and dietary and lifestyle management, taking care of blood pressure, blood glucose. And if TSH is more than 10, we give levothyroxine. TSH less than 10, especially in elderly women. Again, there was a huge trial which placebo versus levothyroxine. Levothyroxine, in fact, increased mortality because most likely because some may end up having iatrogenic thyrotoxicosis, and that in turn may be more harmful than any benefit. So TSH more than 10, we will treat. TSH less than 10, we will avoid giving thyroxine. If we are giving, we have to be really careful about monitoring. It's a U-shaped curve. Both high and low TSH are associated with high CV risk.
Okay. Thank you, ma'am. I think there are no more questions. We can now conclude the session.
Yes, thank you. I would like to thank Dr. Beena Bansal for giving an excellent talk on the subject of hypothyroidism and women's health, a clinical perspective. And I would also like to thank Dr. Manasi Harale for coordinating this session and also for the previous session as well. So thank you once again. And with that, we conclude this session and move on to the next session.
Thank you.
So after the wonderful session on hypothyroidism, we now move on to the next session, which is on rethinking hypertension and NAFLD. And to chair this particular session, I would like to invite Dr. Alok Modi and Dr. Vedavati Purandare. So can we have the CV slides, please? Can we have Dr. Alok Modi's CV slide, please? Yes, so Dr. Alok Modi has done his MD in medicine from the State GS Medical College, Mumbai, and he has also done his FACP and critical care training in the US. He has been an ex-faculty at the Rajiv Gandhi Medical College, and he's presently working as consultant physician and diabetologist at the Jupiter Hospital, Apollo Clinics, and the Kaivalya Hospital. He has been the faculty in Epicon 2017, been part of the expert panel on saroglitazar. He has been part of the Critical Care Summit in the US in 2013, and he has been certified by the ADA South Asia Pacific region as a qualified trainer in diabetes. He has several publications and presentations at various conferences and in peer-reviewed index journals. Welcome, sir, to this session. Now, can we have Dr. Vedavati Purandare's CV slide also, please?
Thank you. It's not very audible from your end.
Is it audible now?
Little soft.
Okay, I'll speak a little loudly if that helps.
Yeah.
Yeah, okay. So with me, as you can see, is Dr. Vedavati Purandare, who is a consultant physician and diabetologist at the Chelaram Diabetes Institute. She has done her MBBS and MD in medicine from BJ Medical College, Pune. And she has also recently completed her PhD, which is not visible in the slide actually. She has received the Dhirubhai Ambani scholarship and has been awarded with the late Mr. Vasant Baum Prize for her academic performance. She has several scientific publications in index journals, and she has also made a number of presentations. And she has, of course, been a part of various training programs and research activities which we conduct at the Chelaram Diabetes Institute. So with that brief introduction, now I request both the chairpersons to take over and lead this session.
Thank you so much, sir. It is nice to see the speakers as well as the chairperson, Dr. Alok Modi and Dr. Supratik Bhattacharya. May I have the CV slide of Dr. Supratik? So Dr. Supratik would be talking on managing hypertension with diabetes, advancing beyond arbitrary BP values. He has done MBBS, MD, MRCP, FRCP, FACP, and MS in endocrinology and diabetes. He is director of SKN Diabetes and Endocrine Center at Kolkata. He is consultant Department of Endocrinology in Kolkata and has various publications in the national and international papers, authored various chapters in various books, part of multiple phase 3 and 4 clinical trials, has received many awards, and his ACP Governors Recognition Award he has received for exceptional contribution as Scientific Secretary ACP India Conference 2021, and also he has received one award given by RSSDI in 2020, Best Innovation in Diabetes Care During Challenging Times. Over to you, sir.
Right. So thank you so much, Dr. Unni and Kavita and the entire team of CTI. Thank you, Dr. Vedabati and Dr. Alok Modi, who is a close personal friend of mine, and it's an absolute pleasure to be here. So I'm just here on board, and I'll be here to take the questions after this session.
So, good evening, everyone. Thank you, Dr. Unikrishnan, AG, for your kind invitation to speak at this platform. And today I'm going to talk about hypertension with diabetes and advancing beyond arbitrary BP values. I've been kindly introduced by the chair. What exactly is opposite of arbitrary? So anything that is rational, reasonable, democratic, regular, logical, sensible, consistent would be considered as non-arbitrary. So when we're talking about the blood pressure, how low to go? So there is concordance between the various groups. And if you're looking at EAC or the ACC, they say that you can go below 130, but not lower than 120. Similar, if you look at the EAC 2018 or ACC 2017, they talk about going below 140 and even below 130 if tolerated. Now you're pulled in many directions and you're sometimes confused as to how low to go or what exactly should be your target blood pressure. The reasons for inadequate blood pressure control would be physician inertia, ineffective drugs, resistant hypertension, but most importantly, we're talking about the guideline confusion and of course the drug costs, the side effects, poor compliance, etc. come into play as well. So let's look at a case scenario, and this is a 52-year-old woman with type 2 diabetes, who's been diagnosed about 2 years back, and now she comes with a clinic blood pressure of 160/100, and this is very similar when you ask her to record the blood pressure at home. So type 2 diabetes, dyslipidemia, this is the medical history. She's currently on gliclazide metformin combination with a rosuvastatin 20 mg. If you look at the clinical evaluation, there is nothing majorly wrong except for the blood pressure, which is about 160/100. There's no signs of any retinopathy. There's no clinical evidence of any congestive heart failure or peripheral vascular disease. However, when the lab reports come back, you find that there is stress protein, and also the serum creatinine is about 0.9, which makes it eGFR 75, corresponding to a CKD stage 2. And 24-hour urine collection shows that the urinary albumin excretion ratio is about 250 milligrams per day. So the patient is diagnosed to be having hypertension with type 2 diabetes and also CKD and microalbuminuria. What should be the clinical approach in this case? Should her blood pressure be treated? What treatment strategies should be used? So let's look back. Hypertension in India, the current scenario, there are more than 250 million people suffering from hypertension, and the prevalence of high blood pressure in adults aged more than 30 years or older, and 1 in 2 patients with diabetes also suffer from hypertension. And what are the hurdles to blood pressure control? At diagnosis, there could be screening what is not done properly or the diagnosis is not met. Similarly, there are hurdles during the treatment regarding no protocol, as we were talking about, drug shortages, etc. And then, of course, there is continuity of care. So there are constant struggles to meet the blood pressure target. If you're talking about the hypertension, this is a deadly duo, and we know there's a common soil for both diabetes and hypertension in the forms of insulin resistance, dyslipidemia, obesity, and also genetic factors which drive both diabetes and hypertension. This leads on to atherosclerosis, endothelial dysfunction, vascular inflammation, vascular fibrosis, and arterial remodeling, which can either lead on to macrovascular complications or microvascular complications. When we're talking about the combination of diabetes and hypertension, this can lead on to microvascular complications. More than 70% end-stage renal disease in US, for example, is attributed to a combination of hypertension and diabetes. We're talking about the heart diseases, 3 times more likely chances of chronic heart disease, LVH, and also 3 times likely to develop congestive heart failure. Similarly, high chances of peripheral vascular disease and also cerebrovascular diseases like brain strokes. So hypertension and diabetes, patients are high and very high CV risk. 40% of the patients with type 2 diabetes have hypertension at the time of diabetes detection, and also diabetic patients with hypertension are also increased risk of worsening cardiovascular disease or CKD. So for each 20 millimeter mercury rise in the systolic or 10 millimeter mercury rise in the diastolic, we see that the CV mortality risk doubles. So for example, anyone with a systolic blood pressure of 175 and diastolic 105 is at 8 times more risk of developing cardiovascular mortality as compared to somebody who is having a systolic of 115 over a diastolic 75. Microalbuminuria is an established marker for early renal disease. Not only that, it's also a marker for future cardiovascular mortality and morbidity, and we have one evidence for this, and we need to measure serum creatinine and eGFR, and this is recommended in all hypertensive patients. Now, if you're having diabetes with hypertension, that naturally puts you at a higher risk, and if you look at the risk stratification, so anyone, say for example, who is having hypertension, along with that, if they have diabetes, they're at advanced stage. Or similarly, with anyone with diabetes with organ damage would be rated as very high risk, for example. Now, we risk stratify the patients and then determine the blood pressure goals. So for example, anyone with atherosclerotic cardiovascular risk of more than 15%, we target the blood pressure to less than 130 over 80. And anyone with atherosclerotic cardiovascular risk of less than 15%, even in those patients, we try and lower the blood pressure to less than 140 over 90. And there are specific groups of drugs which should be used while we're considering treating hypertension in diabetic individuals. For example, ACE or ARBs in general should be used ahead of others in type 2 diabetic patients. And also we should be thinking about calcium channel blockers and thiazide diuretics. This is a recommendation that has been given to anyone with hypertension and diabetes. Again, if you look at the various brackets, we need to lower the systolic blood pressure as well as diastolic blood pressure to the target levels of less than 130 if it's 18 to 65. Similarly, less than 140 or 130 in 65 to 1679, and anyone with more than 8, even then, we need to lower the blood pressure to less than 140. The diastolic in general should be targeted to around 8 millimeter mercury. So what about the strategy in patients with diabetes and hypertension? It's recommended to initiate treatment with a combination of a RUS blocker with CCB or a thiazide or thiazide-like diuretic, and we have 1A evidence for this. What about the treatment recommendations to achieve the target blood pressure? So again, there's uniformity between the various guidelines, whether you're talking ADA, ACC, EAC, for example. They all talk about if you need to use a multiple drug therapy, you should be considering ACE and ARB, along with that a thiazide-like diuretic and a calcium channel blocker. So this was my study that was presented and it was published in Journal of Endocrine Society back in 2020, and wherein I showed that anyone with diabetes and hypertension, most of them required more than one drug to achieve optimal blood pressure control. Advantages of fixed dose combination for hypertensive patients. We know that single pill fixed dose combinations offer stronger and faster blood pressure control, and there is also increased or improved adherence and help reproduce results of clinical trials in real practice. This is the stepwise approach that we usually see, and if you're considering AB and ACE inhibitors or ARBs as the A, calcium channel blockers as C, and D as thiazide-like diuretics. So you can start off with, for example, single pill combination of ACE ARBs along with a calcium channel blocker, and if needed, you bring on board a diuretic or the other way around. Now, the advanced trial showed a very different way of approaching hypertension, and there was a difference from the traditional treat to target approach, which sets the blood pressure levels at which the treatment initiated and titrated. And this would involve resource-intensive management with multiple patient visits, careful monitoring of blood pressure and side effects, coordination of complex drug regimens, and also makes only few patients achieve recommended BP targets. Whereas the alternate approach was involved in the advanced study, where irrespective of the initial blood pressure level or background antihypertensives, everybody was started on a RUS blocker with a thiazide-like diuretic fixed dose combination, and this was done for everybody, and more inclusive and less resource intensive and target setting strategy. Shift the entire distribution of blood pressure values down with the minimum requirement for titrations and fewer side effects. So the combination that was used was perindopril with indapamide in particular. And let's look at the renal benefits of using this combination irrespective of the baseline blood pressure. And you can see in here, perindopril indapamide combination, whether you're looking at the various systolic or the diastolic blood pressure brackets, anyone with more than 160 or from 140 to 159 or from 120 to 139, and even those individuals with a systolic blood pressure of less than 120 benefited from the combination of this RUS inhibitor and thiazide diuretic in terms of renal outcomes. Similarly, anyone with a diastolic blood pressure at any bracket, whether it was more than 90, between 80 to 89, 70 to 79, or even less than 70 benefited in terms of future renal outcomes in using a perindopril indapamide combination, irrespective of the baseline blood pressure. This triple protection was seen with the single pill combination of RUS inhibitor and thiazide diuretic, perindopril indapamide, and there was 21% prevention of microalbuminuria, 16% regression of macroalbuminuria, and 24% retardation of the worsening nephropathy. Also, there was a major sort of implication that came out from this trial. There was Advance On was the first trial to confirm vascular legacy, and Advance On, of course, is a take on from the Advance trial, and this was the only study that came up and showed vascular legacy. Previous to this, UKPD's hypertension diabetes study that was done back in 2008 did not show any legacy effect, whereas the Advance On published in NEJM in 2014 clearly showed that there was a vascular legacy that came out from the study. Now let's go back to a clinical case that we presented of the 52-year-old woman with type 2 diabetes and uncontrolled blood pressure. So this was the scenario, and we know that she was having hypertension, which was uncontrolled, type 2 diabetes, CKD, and microalbuminuria. Now, should her blood pressure be treated? The answer is clearly yes. What treatment strategy to be used? So the most rational combination will be a RAS inhibitor and a thiazide-like diuretic, or you can think about a calcium channel blocker as a single pill combination. And once you have started the single pill combination of the perindopril indapamide like combination, what happened was the patient came back and the present blood pressure was 124/82 is what you wanted. And of course, you see that the creatinine has come back to 0.7. That makes a EGFR around 96. That's CKD stage 1. If you remember, she was in CKD stage 2, so there's a regressional stage. And also, if you look at the 24-hour urine collection, the urinary albumin creatinine ratio was 28 milligrams per day. So that also, there was a reversal of microalbuminuria. Control of hypertension and appropriate single pill combination was reversal of microalbuminuria and regression of the CKD state. So this is in general the outline and recommendations for treatment of confirmed hypertension. So you see, anyone with the initial blood pressure of more than 160/100, you're absolutely okay to start with agents straight away. And if there is albuminuria, of course, you should be thinking about ACE and ARBs ahead of others. And also those combinations or the single pill combinations which has got evidence in terms of preventing renal outcomes, like the ones we have shown in the form of combination of perindopril and indapamide. So this is a rational recommendation that has been set out. Single pill combinations of ACE ARBs with either a diuretic or a calcium channel blocker, as we had been talking about. And if uncontrolled, then you go on adding multiple agents. So triple drug combination as first-line therapy for uncontrolled patients on type 2 diabetes. The study that was done, this was called the Advanced CCB study, wherein perindopril indapamide, along with the CCB treatment, offered significantly 28% reduction in the total mortality. And you can see in here, versus the Advance, there was a much higher reduction in the total mortality with the Advanced CCB trial. And also the triple drug combination of perindopril, indapamide, and amlodipine did show a strong blood pressure reduction, whether you're talking about the systolic. There was a drop in almost 37 millimeter mercury, and diastolic almost 18 millimeter mercury, which means that 90% of the patients did achieve their target blood pressure. Now, latest Indian study of the triple combination demonstrated a very strong blood pressure reduction. So there was a drop in systolic by almost 27 millimeter mercury and diastolic by almost 8 millimeter mercury in the hypertensive diabetic individuals. This was my study that was done with the same combination, perindopril, indapamide, and amlodipine. And this was done for those patients who had initial blood pressure systolic around 160 to more than 160, or a diastolic more than 90 or 100. And we know that from the hypertension screening and treatment program study that anyone with a baseline of systolic blood pressure between 160 and 179 they had twice as likely chances to be dialysis dependent in future, and they need to be treated. So the aim was to identify those individuals with a systolic more than 160 or a diastolic more than 90, and they were initiated on a fixed dose combination of indapamide, perindopril, and amlodipine, and their blood pressure was monitored subsequently over the next 12 weeks. And the patient's blood pressure was recorded and initiated after initiation of the fixed dose combination. And this is how their blood pressure changed over time. At the baseline, the mean systolic blood pressure was around 168. That fell to around 145 at the end of 4 weeks. And at the end of 12 weeks of the study completion, it was around 131. Similarly, if you look at the diastolic blood pressure, the baseline mean diastolic blood pressure was around 100, dropped to around 88 at the end of 4 weeks. And at the completion of the study at 12 weeks, it was around 82 millimeter mercury. All patients continued their treatment for the entire duration. Only 1 out of the 50 patients complained of first dose hypotension. There was no postural hypotension that was noted at all. Beg your pardon. So this is a typo. So we're talking about no postural hypotension. So the key take-home messages that we had were studies have shown only 10% patients with single agent did manage to achieve the target blood pressure in type 2 diabetic individuals. And 40% eventually required a dual agent, and almost 50% required a triple agent to get to the target blood pressure. And a vast majority requires triple agents, as we were talking about. A fixed dose combination of indapamide, perindopril, and amlodipine has shown to be effective in lowering both systolic as well as diastolic blood pressure in type 2 diabetic individuals significantly without any additional safety concerns. The triple drug combination was well tolerated. It increases treatment compliance and is a rational combination which addresses basic pathophysiology and may be routinely used for initiation in patients with high baseline blood pressure instead of the conventional stepwise approach. So limitation of the study was that it was a relative small sample size, and this was presented at APCH in 2021. To summarize, we know that the guidelines recommend initiation of single pill combinations to increase the compliance and also get to the target faster in managing hypertensive individuals with diabetes. Single pill combinations of RAS inhibitor and thiazide diuretic and/or calcium channel blockers would result in substantial reduction in major renal events and all-cause mortality. And also, as we see from the ADVANCE-ON study, there are vascular legacy benefits that are seen and is well sustained over time. So probably time has come to move beyond, like setting targets and try and use rational combinations, which not only does justice in terms of reaching the blood pressure targets, also gives organ protection, which is our ultimate aim. With this, I conclude, and we need to base our clinical practice based on evidence, but something which is going to be very simple for everybody to follow. It should not be confusing for others. And of course, the single pill combinations goes a long way because of the increasing compliance, easy to up titrate, and also to achieve the targets faster. So once again, thank you, Dr. Unikrishnan, for this kind invitation, and thank you, chairs. Be available now to take any questions that you have for me.
Thank you. That was really wonderful, Supratik. As usual, it's a pleasure and it's an honor to listen to you. A very huge topic covered very succinctly, a very incredible presentation. I would request the other chair, Vedvati ma'am, if she has any comments to make.
Excellent session, sir. And we liked your thank you slide where the Dhanyavad was colored. Thank you so much. Sir, two small questions. Your personal experience regarding your sartans, azil sartan, And also when our patients on amlodipine, when they get ankle edema and then we switch to cilnidipine, how potent is the cilnidipine as compared to amlodipine? So in clinical practice, many physicians face this issue. So azilsartan potency and
So I think azilsartan came up in a big way, and it was showing evidence in terms of better 24-hour blood pressure control. Unfortunately, I don't know why it is not used as much, but I think it's a very good molecule to have on board. So I would love to hear your experience, Dr. Modi, and your experience regarding the azilsartan molecule. I had been using it routinely, and it's unfortunate the noise level has gone down regarding that, but I think it's a good molecule.
I'm not sure, but I think there were a few case reports about increased nephrotoxicity with this.
Yes.
I think it was brought in with a better promise of a better decrease in UACR and EGFR, but I think it didn't happen that way. So probably the noise has gone down. I haven't seen a lot of benefit with cilnidipine over amlodipine as far as the peripheral edema is concerned. So they say because the air channels are blocked with this, which is not the case with amlodipine. I don't know. I mean, I may be wrong. I don't know about your experience. I have actually one question, Supratik. It's nice to get the figures down in a patient with blood pressure. And similarly, it's nice to get the sugars down in a patient with diabetes. But what we're really looking for today is not the values. What we are looking for today, of course, the values do make a difference, obviously. But we're looking for organ damage. We're looking at a health. I talk to my patients like, it's nice to get a salary. It's important to invest it properly. Just putting it in the bank or in the house is not the way to preserve money. You need to invest it in the proper market so that your money grows into you. So it's important that we choose the right medications and lifestyle so that the organ damages are limited. There's no point if the person's blood pressure is under control, but he lands up for a pizza after 10 years, he lands up for a dialysis after 7 years. And we know that microalbuminuria and all start within 7 years of the onset of these diseases. So I wonder if there is any guideline or there is some kind of a scoring system by which we can monitor the kidney echoes, look at the heart failure with preserved ejection fraction, not with the reduced ejection fraction. Look at the micro, look at the EGFR, look at the retinal damage with the OCT, and sort of come out with an equation which can guide us about the therapy and the long-term prognostic management, and thereby decide a good goal-based therapy for a better decrease in morbidity, not mortality. And how do you,
I take your comment on board completely. Before that, I'll just go back and answer the question that we had comparing between cilnidipine and amlodipine. Of course, one thing that cilnidipine is sort of scored off, saying that it's not a potent molecule, but sometimes we fail to up titrate the dose of cilnidipine. It's always used at a dose of 10 mg, and then it's compared with amlodipine and said that it's probably not as potent. So we want to ensure that we're actually up titrating the dose of cilnidipine properly. Of course, there is mechanistic benefit, as we all know, regarding the pedal edema, and obviously, theoretically, since amlodipine can cause pedal edema in those with CKD, there is a concern regarding that, and so that has to be kept in mind. But regarding use of cilnidipine, we have to ensure that before we write it off, we need to ensure that we are up titrating the dose adequately. Now, coming back to your question, as we said, as we had shown you in the background study that we did, so anyone with a background or a baseline blood pressure systolic more than 160 or 100, they straight away have much higher chances of ending up in end-stage renal failure. So we need to be very proactive. So we have to come off from the stepwise conventional approach and think about like how we are treating diabetes. We've come off from just treating dysglycemia, and we are going more into a direction of organocentric approach where we're trying to protect the kidneys and the heart. I think the same approach should be used in case of antihypertensives as well. So use a rational combination, use multiple drugs if required from the very beginning, because in my study that I had done, I saw that tolerability is not a big issue. There was not much of first dose hypertension or postural hypertension that I would have expected. So I think It's only that if you use it in your clinical practice, and I say, like, the proof of the pie lies in eating it. So you use this and see for yourself, and then only we can change the practice, clinical practice in general.
Over to you, ma'am.
So thank you so much, sir. It was a really wonderful session, and thank you, Dr. Alok Modi, for joining the session. Now we proceed for the next session, and we have eminent speaker, Dr. Rita Basu. She is known to us since many years. She is part of our CDI family, and welcome, ma'am, for the 6th International Diabetes Summit, which this year is also virtual. So hope that we meet physically next year. We have offline conference. So can we have a CV slide of Dr. Rita Basu?
Actually, morning, Veda, and good morning, everyone. Thank you for the honor. I love presenting at the International Diabetes Summit. As it's good to see you, Veda, and I thank the organizing committee, including yourself and Dr. Unni, for giving me the opportunity. I actually have to share my slides because, but they took away that I was going to go and share my slides with you guys. I have it up on the screen. So can I?
Sure, ma'am. Sure. I will introduce you. I will read the CV slide, and then you can share your slides, ma'am.
Got it. Thank you.
Yes. So Dr. Rita Basu would be talking on what future treatments are on the horizon for NAFLD. We all know that NAFLD is commonly seen in type 2 diabetes, and yet there is no consensus as such for the treatment. So Dr. Rita would be talking on it. She is Professor of Medicine, Center of Diabetes and Technology, Division of Endocrinology at University of Virginia School of Medicine. She is ex-professor of medicine in the Division of Endocrinology, Diabetes, Metabolism and Nutrition at Mayo Clinic, Rochester, USA, and chairperson of the Institutional Review Board for the Mayo Clinic Office of Human Research Protection. She is involved in various studies for the NIH, member of the Data Safety Monitoring Board for large multi-center NIH-sponsored clinical trial for restoration of insulin secretion in pre-diabetes. We have worked for one study on pre-diabetes. Then she's associate editor to the Journal of Diabetes Technology and Therapeutics, as well as on the editorial board for AJP Endometabolism. Her research interests lie in mechanism of insulin resistance in pre-diabetes, type 2 diabetes, the regulation of hepatic cortisol production via 11-beta hydroxysteroid dehydrogenase enzymes in steroid-induced diabetes, then pathophysiology of NAFLD and NASH, as well as subcutaneous glucose transport, continuous glucose monitoring, neurosensors for the use in type 1 diabetes, and the artificial pancreas program at Mayo Clinic. Over to you, ma'am. Now you can share your slides.
Thank you, Veda. That was very generous. So, as I mentioned, it's an honor to present here, and I hope you can see my slides.
No, ma'am, we can see you and hear you, but we are not able to see the slides.
1 minute.
Yes.
Let me get to, okay, share. Can you now see my slides?
Yes, yes, we can see them.
Awesome. Thank you so much. So I won't waste any time. Let me get started. So the topic that I was asked to present, the first one, is what future treatments are on the horizon for NAFLD. So I have no relevant, the relevant financial relationships are listed here for Astra and Abbott Diabetes Care, and no off-label usage. So essentially, when you think about NAFLD, defining it is very important. So there must be an evidence of hepatic steatosis, either by imaging or histology, and lack of secondary causes of hepatic fat accumulation. So that's important. And then in most patients, non-alcoholic fatty liver disease is commonly associated with metabolic comorbidities, which is why we're discussing it today. So what are the common complications associated are obesity, diabetes, and dyslipidemia. So the objective today is to talk about the drugs first. What are the new drugs that are coming up? As we know, there's no FDA, US FDA approved medication for the indication that I'm discussing. So the first one of the drugs that came up and is still not approved, but I thought we should start here, is obeticholic acid. This is the trial design. There were about 2,500 patients randomized 1:1:1 with placebo or OCA at 10 milligrams or OCA at 25. And of course, they did some, they had to do biopsies in the beginning, and then they followed the patients up for over 48 months. And they did an interim analysis with some at 18 months with primary endpoints. And what they looked at was fibrosis improvement by greater than 1 stage with no worsening of NASH, or NASH resolution with no worsening of fibrosis. And the study success was defined. Sorry, the slides just went through. It was one of the 2 primary endpoints, okay? So what the results showed was, even though on the graph on the left-hand side, if you look at it, that it did show that there was an improvement by greater than 1 stage with no worsening of NASH. But when you looked at resolution with no worsening of liver fibrosis, it was not significant, which is the middle panel. And so, this, though this drug showed a lot of promise, but there were other problems with it which precluded FDA approval at this time. And I'm sure you've all read about it. So I'm going to talk about some of the other drugs that are now being tested and tried, and they're showing some good promise. So as you can see, there's so many different pathways that people are looking at when they are trying to attack this problem of how to treat patients with NAFLD-NASH, because it's not a very simple disease. It's got multiple pathways that could be affected. So the key pathways are listed here on the slide, and I'll take you through them one by one. I want to thank Dr. Nureddin for sharing the slide with me. So one of the first drugs that I wanted to talk about is resmetirom, MGL3198, which was used. It's a multi-center, randomized, double-blind, placebo-controlled phase 2 trial. And they tried the drug first for all doses, and they looked at then 60 milligrams and 80 milligrams at 36 months post-treatment. And what they showed was there was a good relative reduction in hepatic fat, as you can see. In the higher doses was almost up to a negative 50%. And if you look at the absolute reduction in hepatic fat, that also seemed to look good. So for the treatment of this drug, the most important points that they looked at was greater than 2-point NASH reduction, which was significant, versus placebo, NASH resolution without fibrosis worsening, and the response to fibrosis responder was not significant, but this drug nevertheless is showing some promise. So what are the different treatment trials that are going on right now? As you can see, long laundry list, a lot of drugs being used, lanifibranor, semaglutide, there's other combinations with various types of agonists, antagonists, etc. So I'm going to take you through some of these because none of this is approved, but they're still going on. So if you look at the first category is the PPAR agonists that have shown a lot of promise. One of the drugs has been approved for an indication in India that the saroglitazar, and they're doing trials here. Now, elafibranor, saroglitazar, lanifibranor are all being tried out. These are all different types of PPARs. Some are pan-PPARs, some are just attacking one type of PPAR agonism. So the pan-PPAR agonist lanifibranor resulted in highly significant improvements in both resolution of NASH and regression of fibrosis at 24 weeks in a non-cirrhotic NASH population. These are the results of the native phase 2b trial, and this was previously published in the NEJM, and many of you might have already read it. So the trial design is presented in the nct.gov, but if you look at it, it was a 24-week treatment with its double blind with placebo, lanifibranor at 800 milligrams once daily, and then lanifibranor at 1,200 milligrams once daily with a screening liver biopsy and end of treatment liver biopsies. So they're still sort of looking at the histology and coming up with their conclusions based upon the histology. And the main inclusion criteria were patients who had biopsy-proven NASH confirmed by central reader, which is very important for these trials, and looking at the steatosis activity scores for steatosis, activity, and fibrosis. So they have a scoring system. And this trial, there was statistically significant resolution of NASH and no worsening of fibrosis. They had very significant p-values at both doses of the drugs that they used. They also had an improvement of fibrosis by at least one stage and no worsening with the higher dose of lanifibranor, and then resolution of NASH and improvement of fibrosis in both doses of the drug used. So this was consistent response in both patients with diabetes and who did not have diabetes, and they presented this as a poster. If you look at the safety of this drug, so what they reported was all the adverse events, and the most important ones were some increase in weight, some peripheral edema, and some increase in transaminases, which I've listed. And the others, of course, as expected, there's some GI side effects, etc. But it still showed some promise. If we go to the next set of drugs that I think are showing a lot of promise in NASH are the GLP-1 agonists. So liraglutide started off first, and now we are using a lot of semaglutide in various clinical trials. So this trial was looked at the efficacy and safety of subcutaneous semaglutide once daily versus placebo in patients with non-alcoholic steatohepatitis. Again, it was published in the NEJM, and Dr. Harrison was the lead author. So the trial design was to compare the effect of 3 different doses of semaglutide subcutaneously once daily versus placebo, and looked at the histological resolution of NASH. So the eligible patients would have biopsy-confirmed NASH, NAFLD activity score greater than 4 with fibrosis either stage 1, 2, or 3, BMI greater than 25, and HbA1c less than 10%. And they gave them this nice trial design that I've shown you here, 3:1, 3:1, 3:1 design. And the primary endpoint was resolution of steatohepatitis and no worsening in liver fibrosis in patients with a baseline fibrosis stage 2 or 3. And they did a confirmatory secondary endpoint, which is improvement in liver fibrosis and no worsening in steatohepatitis with baseline fibrosis stage 2 or 3. So the patient disposition was as shown here. They screened about a little over 1,000 patients, and then they randomized them to these various arms, and they completed treatment. So withdrawal from trial death, I show because it's important. I'm an IRB chair. I always look at the adverse events. So as you can see, there is some withdrawal from the trial or death reported, and but they are mainly withdrawals because the number of deaths related is really none or to 1. Resolution of steatohepatitis and no worsening in liver fibrosis was shown here. As you can see, it was highly significant for almost all the arms and all the doses they used. So you see the high significant p-values, whether they used the 0.1 versus the placebo, or the 0.2 versus the placebo, or the 0.4 versus the placebo. So it is very, it was good trial results. If you look at improvement in liver fibrosis and no worsening in steatohepatitis, the picture is not that great. So as you can see, none of the p-values was significant. So of course, this was a setback that it didn't show any improvement in liver fibrosis. And if you look at changes in body weight and HbA1c, so body weight on the left-hand side panel, as expected, with the class of drug that we're using, there will be a drop in body weight, and it sort of seems to be dose dependent. And if you look at HbA1c, also they had some success, as expected. We know this from our utilization of this drug for management of patients with type 2 diabetes. So no surprises here that it helps lose some weight, and it improves HbA1c for the patients that had type 2 diabetes, which is about 200. What about the adverse events? So of course, as expected, GLP-1 analog vomiting is a very important side effect. And if you keep giving higher and higher doses, that's probably going to happen more and more. And so that's what they found. And so that was the significant one. And of course, some of the other GI side effects, again, all expected. What about the other safety outcomes of interest? So gallbladder related disorders, I highlighted them in red. So draws you to that, and severe hypoglycemic episodes in patients with type 2 diabetes on treatment. So those were the two things that one needs to keep in mind. Other than that, everything else is as expected. So I think I have 8 minutes left. Okay, so I'm going to go to another class of drugs that we can talk about. There's the ACC inhibitors, and then there's the FXR agonists. So as you can see, we are going to various pathways that could be affected, and we are looking at various drugs. So the next drug that I want to talk about is a combination, because as I mentioned, it's a multi-system disease. So you need to use multiple drugs to treat these patients. So this is combination therapy using semaglutide, cilofexor, and firsocostat in patients with NASH. Here's the study design. So they're using various combinations of semaglutide with FIR or silo, and they're giving different doses. The key inclusion criteria were histologically confirmed NASH with NASH CRN F2, F3 equivalently, or clinical diagnosis of NAFLD using MRI PDFF scoring of less than 10%, and looking at FibroScan scoring greater than 7 kilopascals, or using a fibro test. The randomization was stratified by diabetes mellitus, and it was 1:1:1:1:1, and of course, open label. So MRI PDFF was what they used to do this. So again, a shift now, they're not using biopsy, they're using imaging technique, and they looked at greater improvements with combination therapy. So again, this was the greatest reductions in PDFF was in FIR groups, and this had similar findings observed with the CAP scoring. So this is a shift now where we are trying to do more and more non-invasive testing to come up with our study endpoints, because we've done enough where we compare the histology to the imaging, and we think we have good correlations. So what about the improvements in ALT, AST, and CK18 with the combination drugs? So if you look at I would say the most important scoring system that we use now is the ELF scoring. There was significant improvements. So of course, if we look at improvement of ALT, AST, etc., yes, those are happening, but most importantly, there was a reduction in ALT in all combinations versus semaglutide alone, and in the ELF scoring. So that's important. And reductions in liver stiffness was done by VCTE, which, as you know, is a FibroScan. And they showed similar reductions in by VCTE between the treatment groups, and they showed no differences in MRE. So they preferred, this is a better, they did both analysis, and VCTE seemed to show up better data. Let's go to the last type of drug that I want to show, because I know I have a few minutes left. And this is galectin-3 inhibitors. And the drug that we've been using is belapectin, which is GRMDO2. So this is in phase 3 now. So the mechanism of action is through targeting fibrosis through the galectin-3 inhibitor pathway. So this drug, belapectin, is an inhibitor of galectin-3, and it's being tried out in patients with NASH who have cirrhosis and portal hypertension. So, as I mentioned, no one drug is going to solve the problem of NAFLD and NASH, because it's multifactorial, plus it has staging. So for various stages, we'd be requiring to use various drugs. So in this trial, which was published by Dr. Chalasani in Gastroenterology in 2020, what he showed, he used belapectin 2 milligrams per kilogram, small trial, of 54 in that group, 8 milligrams per kilogram dose, and versus the placebo. And he was particularly interested in looking at patients who had cirrhosis and portal hypertension, and he showed some good data. There were significant differences. So my slides are jumping ahead of me, so it cut me off. This is all timed because I wanted to stay at 20. So, these are some of the data I wanted to show you guys. I know it's a very short talk, so I didn't want to overwhelm everyone. So I wanted to end early and give more time for questions. So I'd like to stop here and see if you guys have questions.
Thank you so much, ma'am. It was a wonderful session, and there are so many new drugs actually means we cannot pronounce also. These many drugs are there in pipeline, and hope to get at least one which is safe and effective for NFLD patients, and eagerly waiting for one. Dr. Alok Modi, would you like to add?
I couldn't hear that actually. There's a little problem with the voice here. Could you just repeat that?
I'm sorry?
I couldn't hear that. Could I just hear that question again? That comment
No,
again?
sir, there is no question. We are on closing remarks.
No, for that, I was quite impressed with the SEMA data. In fact, I'm quite interested in that molecule. It's coming up in a big way, and Novo is launching it in a huge way. It's an impressive data, and I see a lot of vistas opening up tomorrow for, especially for non-diabetics, pre-diabetics. And it was a very wonderful presentation. It was really lovely listening to your talk. I just have a very, very basic question. What do you think is the role of metformin? Do you think metformin can stand the challenge of the new molecules? Do you think it really is a wonderful drug for this? And do you think metformin should be a mandatory therapy? As of today, there is nothing like a mandatory therapy. What is your opinion about metformin? Since we are Indians, we love metformin.
No, Dr. Modi, it's a great thought, but here's what's happening now. Metformin, unfortunately, great drug for diabetes, pre-diabetes. I still think it's a wonder drug. Does so many good things. Unfortunately, didn't seem to show any effect for the NASH. So when the GI docs are, of course, their life is spent on trying to make sure that nobody gets portal hypertension and gets cirrhotic. So they're more interested in treating the greater stages of fibrosis when patients go to F3, F4, etc., and they want to treat them because that's a very bad sequelae, and they would need, many of them may end up with hep cancer, or they may need transplantation, etc. So their focus has always been treat the patients who are at F3, F4 because they are already way far out there. You and I probably, because we are endocrinology, we are diabetologists, our interest is always prevention is better than cure. So I would say if a patient shows up and they have very, small amount of fatty liver or whatever, fat in their liver, they don't have any fibrosis, and you're just treating them for their metabolic problems. So if they have pre-diabetes or they have diabetes and they don't have any components of NASH, yes, of course, you should put them on metformin and treat them like you would treat any other pre-diabetic or a type 2. But unfortunately, for the trials that use metformin just for the indication of NASH didn't work. So that's why it's still got a question mark on it, and we can't use it for the indication of NAFLD or NASH. But I would say to treat metabolic, yeah, it's still one of our wonder drugs, right? Tried and tested and pretty safe, yeah.
Makes sense actually. That's very logical. But it's a very upcoming subject, very upcoming stream actually. I think a lot of work needs to be done. Probably we'll be hearing a lot more of this with a lot of commoditization in the near future. It's a very interesting area which is developing very fast.
Yeah, one of the things that I try to explain to people is not one drug will work for this. So when they started and they were trying to only think about obeticholic acid or only think about a single monotherapy for NASH, it didn't work. So now we are seeing more and more of these drugs where they're doing more trials with combination therapy, because we know if we use combination of drugs, just like we do for diabetes, not one drug will work, right? You have to add a second drug, maybe in a third drug. So NASH is really a metabolic complication of diabetes. I don't think it's an entity that is any different. If patients present, they have, due to dietary or other reasons, they have hypertriglyceridemia, and you're not controlling them well enough, their diabetes and their lipids, etc., they will advance further and further, and then they'll get they have advanced fibrosis. So I think the endocrinologists and the primary care doctors have a responsibility to manage the metabolic complications better. So I'm hoping, I just served on the ACE committee to write the guidelines for NASH and NAFLD for the primary care doctors and endocrinologists. So that those guidelines should be published soon. And because I was very interested in this and I wanted to give a fair chance to the primary care doctors to address this better, I actually just wrote a review, and it's going to come out in the Mayo Clinic proceedings very soon. And I outlined some management strategies for primary care doctors and for endocrinologists, because I think it gets missed a lot. It gets missed a lot here as well, where patients present with so many issues that the doctor forgets that they could have underlying NAFLD as well, or they may have just a starting fatty liver. And so I think the more awareness we raise, the better it'll be for the future of
I
this
totally
condition.
agree with you. Like, this is something which is really not something that clinicians are really focusing a lot upon. And I would allude this to something like.
I'm sorry to interrupt, but Dr. Rita ma'am's live lecture audience is waiting in Banting Hall. Requesting Dr. Modi sir and Dr. Supratik to join in Banting Hall. Ma'am, hope you had your breakfast. So because
no breakfast needed.
Banting people are calling me, please leave Rita ma'am for us.
Okay, I got to run to Banting. Thank you so
Yes.
much. It was nice meeting
Nice
everyone.
meeting you. Yes, ma'am. Yes.
Thank you so much, ma'am. Thank you for this.
Thanks, Dr. Hune, Dr. Vedpuri. Thanks a lot. Thanks both of you. Thanks a lot.